Very good evening to all of you. I hope I'm clearly visible, audible, right? So I welcome you all for today's session with a new energy, with a new enthusiasm. Today, we all are gathered here. So we will be doing the previous year questions of pathology. Give me a minute. So here today, I am going to cover the previous year questions of pathology of FMG. So this session is specifically dedicated for the FMG aspirants. There, I am going to cover the last 3 year. By last 3 year, I mean the 6 papers. The 6 papers, the previous year questions, specifically which are already asked in your exam of pathology of FMG exam. So without wasting any time, let's start it. Can I start? Can I start? So, you know my way of teaching. Just a second, I'm sorry. You may be knowing my way of teaching that today I will be discussing nearly 40-50 questions. Just a second. So whatever, just suppose I'm discussing the 50 questions. So I will not just discuss 50 questions. I will discuss the 50 topics. So whatever is the question, I'm discussing that topic in detail because it is not the exact question which is going to be repeated in your exam. It is the topic which is frequently asked. So we will do excel in that topic so that if any question is asked from that particular topic, you will be able to solve that. Okay, yes. So last 3 year papers I will try to cover as soon as possible. In the last 3 years, I guess 5 or 6 papers we are going to cover. Okay, so let's start it. Can I start? Can we go ahead? So give me a minute. Let me open your chat box. Just a second. So let's start with the previous year questions of pathology of FMG exam. Okay, so the first question is in front of you. First, you see the question, have a look, guess what is the correct answer, you tell me, and then I will explain that question in detail to you. So see, the first question is in front of you. You frequently get question on nephritic and nephrotic syndrome and on glomerulonephritis. It's a very commonly asked topic in pathology. So read the question, which is a nephritic syndrome? Is it minimal change disease? Is it membranous glomerulopathy? Is it post-infectious glomerulonephritis? Or is it post-focal segmental glomerulosclerosis? What is the correct answer? First, you tell me. Yes. You all are right. Absolutely right. The correct answer is post-infectious glomerulonephritis. Absolutely right. So let me explain for the students who don't know anything about the nephritic and nephrotic syndrome. So I will start from the beginning and I will explain you this topic in detail. What is nephritic syndrome and what is nephrotic syndrome? Okay. Humans have a pair of kidney. You can see. Okay. So all the humans have 2 kidneys. Now inside the kidney we have nephron. Each kidney have 1 million of nephron. So approximately all the humans in 2 kidneys, in pair of kidney, we are having 2 millions of nephron. You can see nephron is the structural and functional unit of the kidney. Okay, so these are the parts of the nephron. You can see in a nephron we are having 5 parts. This is the glomerulus. This is proximal convoluted tubule. You can see this portion. This portion is loop of Henle, in which descending lobe and ascending loop is there, loop of Henle. This portion is distal convoluted tubule and this portion is collecting duct. All these tubules together are known as tubules. All the 4 tubules are known as tubules together except glomerulus. So this is the nephron. Now these are the parts of the nephron you can understand. Now let me explain you what is there exactly. I am teaching you the various types of glomerulonephritis which are coming under nephritic and nephrotic syndrome. So I want you to highlight this portion, glomerulus. If you don't understand glomerulus, you cannot understand what is glomerulonephritis. So let me zoom this glomerulus in front of you. So, okay, so let me draw the Bowman's capsule. This is the Bowman's capsule. Now inside the Bowman's capsule, the afferent arteriole come, form a tuft of capillary and go as efferent arteriole. So this is the afferent arteriole. It is coming, forming a capillary inside the Bowman's capsule and leaving as the efferent arteriole. I am saying this is afferent arteriole and I am saying this one is efferent arteriole. Now in the afferent arteriole, whatever substances which are supposed to be excreted in urine, they will pass from here to here and they will collected here and they are excreted in the urine. They will be excreted in the urine and the remaining substances will go away in the efferent arteriole. So whenever any substance has to cross from the blood to the urine, you can see here we have a substance which is supposed to be excreted in the urine. So it has to cross a barrier to come from the blood into the urine. You can see this is the lumen of the capillary. Okay, it contains blood and it is the lumen of the Bowman's capsule. It contains urine. So from blood to urine, it has to cross a barrier. That barrier have 3 layers. You have to understand the barrier. Barrier have 3 layers. Listen. So the first thing is the endothelial lining. Endothelial lining of the capillary. We know all capillaries have endothelium. So this is the endothelium lining, the first thing. The second thing is the basement membrane of the capillary. Okay, let me draw. This capillary have a basement membrane. Okay, and the third thing, on the Bowman's capsule, there is a lining which is known as epithelial lining. Epithelial lining, visceral epithelial lining. It is also known as podocytes. So these three things are there. So whenever any substance, you see the substance, it's a substance. It want to cross from the blood to the urine. So it has to cross three things: endothelium, basement membrane, epithelium. Endothelium, basement membrane, epithelium. This triad, the triplet is known as barrier. This is known as glomerular filtration barrier. How many of you got the filtration barrier? Give me a thumbs up if you got it. Now you can compare this barrier with a sieve. The sieve, Hindi mein we call it channi. Channi, chai channe ki channi, sieve. Have you seen a sieve at your home? If you want to filter, है ना, your tea. Okay, so that is so you can compare the Bowman's capsule is the cup, and what is accumulated inside the cup, that is tea. You have to compare it with the urine. I know it's a bad simile, but you have to compare it for example, है ना. So here you can see whatever getting accumulated over here is the tea. So it is passing from a sieve. It is passing from a sieve, है ना. If we are taking a sieve, this is a cup. I'm putting a sieve over it and I'm just pouring in. So the tea will pass. Whatever substance supposed to be passed, it will accumulate in the cup, and whatever substance do not supposed to pass, it will gather over the sieve only. How many of you got it? How many of you got it? So this is the filtration barrier. I call the filtration barrier as sieve. Hana? Imagine if the sieve have big holes. If the holes in the sieve, you know, the pores in the sieve get enlarged. So what will happen whenever you are filtering your tea? The substance which is not supposed to be passed, that will also pass inside the cup. You got my point? So inside the blood we have RBCs, inside the blood we have WBCs, inside the blood we have proteins. We do not want the RBC, WBC and protein to be passed in urine. But if the barrier is injured, the pores get enlarged, and the RBC will also come in the urine, that is known as hematuria. The WBC will also come in the urine, and protein will also come in the urine, that is proteinuria. So this disease is known as glomerulonephritis. So give me a thumbs up if you got an overview of the glomerulonephritis. Glomerulonephritis simply is injured barrier. The filtration barrier is injured. That is, the pores inside the barrier get enlarged. So the RBC will also come in the urine, protein will also come in the urine, and the disease is known as glomerulonephritis. So this is the thing I want to explain. The same thing I have shown you here. You can see here is the substance. Here is the substance that is want to pass from the capillary into the Bowman's capsule, that want to pass. So you can see the three layers it has to cross. The three layers. The innermost layer is the endothelium. Okay, this is basement membrane, and on other side it's epithelium. So basically we have a basement membrane at the center. On one side of the basement membrane we always have an endothelium, and on other side of the basement membrane we always have a epithelium. Epithelium of the Bowman's capsule, it is the shape of a foot, that's why known as podocyte. So this triplet is known as barrier. If it get injured, it will lead to glomerulonephritis. Now let me come on the topic nephritic syndrome and nephrotic syndrome. Let me come first on nephritic followed by nephrotic, the two syndromes. Now please understand. Nephritic and nephrotic, both these syndromes are not disease. It is a cluster of multiple type of glomerulonephritis. Now, there are many type of glomerulonephritis. Okay, 9 of them are primary, many of them are secondary, some of them are hereditary. Now, some of them present as nephritic syndrome and some of them present as nephrotic syndrome. So I will give you a list that which glomerulonephritis are presenting as nephritic and which glomerulonephritis are presenting as nephrotic. But before giving you the list, the example, you must understand, ma'am, nephritic and nephrotic hota kya hai? What is nephritic syndrome? What is nephrotic syndrome? What is the difference in their presentation? What is the difference? So let me tell you what is the difference between their presentation. Shall I tell you? Shall I tell you? Yes or no? So listen, I would like to draw two diagrams, back to back two diagrams in front of you to explain the nephritic and nephrotic syndrome. I would like to draw the excretory system in front of you. Okay, back to back, I will tell you the features of nephritic and nephrotic syndrome here on the screen. And definitely you are going to get a question from this topic in your exam. It's very frequently asked question. You can see I've drawn the excretory system. You can see I'm drawing the aorta, and this is the renal artery I'm drawing here. Here also I'm drawing the aorta, and here also I'm drawing the renal artery. Now here I will explain you nephritic syndrome. Nephritic. And this side I will explain you nephrotic. So in back-to-back comparison, it will crystal clear in your mind that what we are talking about. Listen, here in nephritic, let's talk about the nephritic. There are 6 things in the nephritic, 6 in the nephrotic. You have to see the difference. So in nephritic syndrome, what is happening? The kidneys are damaged. You know, each kidney have 1 million nephron. Inside 1 million nephron, there is 1 million glomerulus, 1 million barrier. So that barrier, the channi, the sieve get injured in the nephritic syndrome. So the pores are enlarged. So normally RBC don't come in urine, but here RBC is also coming in the urine. So first thing is hematuria. RBC is coming in the urine, that is known as hematuria. So here hematuria is the first thing. Protein will also come in the urine, so proteinuria, but it's mild. Proteinuria is also there, but write down mild, little bit protein. So mainly blood is coming, but little bit protein is also coming because the kidneys are injured, the barrier is injured, so the pores are enlarged, so RBC is coming and protein is coming. RBC is coming, protein is coming, we got it. Now, why God has provided us kidney? Say, what is the reason? To excrete. It's an excretory organ. Now, both the kidneys are non-functional. Bilateral, both the kidneys are non-functional. So, normally, kidney excretes sodium and water. Now, kidneys are non-functional. So, the third thing is sodium water retention. Sodium and water is not excreted out of the body. They are retained. It is known as sodium and water retention. Okay, because of sodium and water retention, you tell me what will happen to blood pressure. Blood pressure will be high or low? In my body, if there is more sodium and more water in my blood vessel, so my blood pressure will be high or low? So it will be high. So patient will be having hypertension. Okay, and the patient will have edema because more sodium, more water will cause the edema in the body. The reason for the edema is sodium water retention. The reason for hypertension is sodium water retention. And finally, the urine will not come because the kidneys are non-functional. Now, very less urine will come. So patient have oliguria. The last thing is oliguria. So count 1, 2, 3, 4, 5, 6 features. Rather than learning in a list, understand them. So tell me the 6 features of nephritic syndrome. Say, ma'am, first thing, blood will come in the urine. Hematuria. Little bit protein will also come, but write down mild. Little bit protein will come in the urine. Mild proteinuria. Since kidneys are non-functional, sodium and water is not excreted. It is retained in the body. Since sodium and water is retained in the body, patient have hypertension and patient have edema. And finally, urine will not come because kidneys are non-functional. So patient will present as edema. Say yes. Got it? Got my point? Say yes. So I guess it's the previous year questions. Now, I guess this is the previous year question discussion and you already have the overview of the topic. It's not a detailed comprehensive course. The students who want the detailed comprehensive course on this topic, I have already taken on this YouTube channel only my complete pathology course, in which I have completed the complete renal pathology in detail, slowly, each and everything. But this is the rapid revision, I mean the previous year discussion question. So I have to discuss the 50 questions. So I have to maintain the pace. Okay. But there is the option of reducing the speed. Okay. If some student Dhruvit, if you are feeling or KK, you are feeling it's too high, you can reduce the speed. There is an option on YouTube, you may be knowing, you can reduce the speed. Okay. If it is 2x, you can make it, I mean, it is 1x, you can make it 0.5. So you can match there. Your frequency will match that. Okay. So can we go ahead? Can we go ahead? Okay. So this is the basic. Nephritic. Learn the 6 features of nephritic syndrome. Can I come on the nephrotic syndrome? Can I come on the nephrotic syndrome? What is happening in nephrotic? Here also the kidneys are injured. Here also inside each kidney, the nephrons, the filtration barrier in the glomerulus is injured. Here also the pores are enlarged. But here RBC will not come in the urine. No, never. Here protein will come. Only proteinuria. Here there is no hematuria. Here only proteinuria is there, but that is severe. Here also we have proteinuria, but that was mild. Here the proteinuria is very severe. Very severe. So proteinuria is very severe here. Got my point? Proteinuria is severe. Now, most of the protein which is lost here is albumin. Albumin. In the blood, we have albumin. No? That is maintaining the lymphatics. It is backup for the lymphatics. The albumin is there. I mean, that is maintaining the osmotic pressure. Okay. That is maintaining the osmotic pressure. Now, if the most of the albumin is lost in urine, so in the blood, there is less albumin. So the second thing is hypoalbuminemia. Hypoalbuminemia in the blood. So because most of the protein is lost in urine, there is hypoalbuminemia. Now you may be thinking, ma'am, protein is lost here also. Why you are not saying here we don't have hypoalbuminemia? No, here we don't have. Because I insist the word mild. In nephritic syndrome, there is mild proteinuria. Okay, that's why here we don't have hypoalbuminemia. But in nephrotic syndrome, there is severe proteinuria. Most of the albumin is lost in urine. So by most of the protein urine mein loss hua, to blood mein there is no protein, na? Less protein. So there is hypoalbuminemia. What is the function of albumin? What is the function? To maintain the osmotic pressure. That is inward pressure. Now inward pressure is less and outward pressure is normal. It's more. So it will lead to edema. So we have edema here also and edema here also. But the cause is different. People, please, the cause is different. Here, the cause of edema is sodium water retention. But here the cause of edema is hypoalbuminemia. That is decreased osmotic pressure. Please understand. Got my point? How many of you got it? Now, We have liver also. Here, most of the protein is lost in urine. Now, you know, liver synthesized protein. Liver will get a stress. That most of the protein is lost in urine. I will compensate. Liver will compensate. Because most of the protein is lost in urine, liver will try to compensate. So, liver चाह तो हमारा भला करना रहा है. Liver is trying to help us, helping the body by compensating by forming more protein. Because it is lost in the urine. But गलती से वो नुकसान कर देगा. So instead of making protein, liver is making lipoprotein. Lipoprotein is also a protein. So liver is trying to help us by making lipoprotein. Liver is thinking that most of the protein is lost in urine. Let me help the body. Let me compensate. So liver is making lipoprotein. Liver is making lipoprotein. But you know, lipoproteins, VLDL, LDL, HDL, these are lipoprotein. So here, protein ki jagah in the blood, lipid will raise. So patient have lipidemia and the lipid will be lost in urine, lipiduria. So the next two properties are lipidemia and lipiduria. There is lipidemia, there is lipiduria, and finally, there is hypercoagulability. The blood is hypercoagulable. So these are the 6 properties of nephrotic syndrome. Can you enumerate? Can you help? You get maximum questions on that. Tell me the properties of nephritic and nephrotic. Tell me. Who will tell me? On this side, you tell me nephritic. On this side, you tell me nephrotic. Can you tell me the properties? Here also I want 1, 2, 3, 4, 5, 6 properties. Here also I want the 6 properties. First you tell me the 6 properties, both the side, and then I will tell you the examples in each category. Please start saying how many of you got it? How many of you got it? Thank you so much for your compliment, Vikas. Thank you. So I hope you all are getting it, what I'm telling you right now. So tell me the 6 properties of nephrotic. Rather than learning this list, understand in the diagram. I have understood you. I try to make you understand in the diagram. So start with nephritic. Say, ma'am, there is hematuria, the first thing. But here we don't have hematuria. No, hematuria is absent here. We have proteinuria, but we have mild proteinuria. Here we also have proteinuria here. But here we have severe or massive proteinuria. Okay, now here sodium and water retention is there because kidneys are non-functional. So sodium water retention leads to 2 things. Number 1, edema, and number 2, hypertension. So edema and hypertension both are due to sodium water retention. And finally, kidneys are non-functional. Patient have oliguria. The urine is not forming. Less urine is forming. So patient have oliguria. On the nephrotic syndrome, patient have severe or massive proteinuria. Most of the protein from the body is lost in urine. Okay, so patient have less protein in the blood. So there is hypoalbuminemia. Hypoalbuminemia is there. Less protein in the blood, which will lead to edema. So severe proteinuria leads to hypoalbuminemia and hypoalbuminemia leads to edema. So edema, we have both the places, but here the reason for the edema is this, and here the reason for edema is this. These all are your PYQs, believe me. Got it? The next thing, lipiduria, lipidemia, and hypercoagulability. So you have to learn. This is for the compensation by the liver. Liver is trying to compensate. Now please, people, learn the examples both the side. So here we have most common cause of nephritic syndrome is RPGN, rapidly progressive glomerulonephritis. Apart from that, we have PSGN, which is our question right now. PSGN is also there. Okay, PSGN and MPGN, membranoproliferative glomerulonephritis. On the other side, here in nephrotic syndrome, we have, here this is the most common cause. What is the most common cause of nephrotic? It is different in adults and it is different in children. So you have to tell me 2 most common cause. In adults, it's focal segmental glomerulonephritis. Okay, glomerular, and in children it is minimal change disease. So learn the 2 main causes of nephrotic syndrome. Apart from that, we have other causes also. IgA nephropathy में both presentation, membranous glomerulonephritis में both presentation. So learn the most common cause. How many of you got it? Now you get very frequent question. How is the question coming in your exam, FMG exam? Which of the following is the feature of nephritic, or which of the following is not a feature of nephritic? Which of the following is a feature of nephrotic or not a feature? So one of the feature will be from the other side. So if you know the list and if you know the examples, things are super duper simple. And most importantly, you get one more question. What is the cause of edema here? And what is the cause of edema here? So you get question on this also. Everyone give me a thumbs up. Jitne live, utne thumbs up. How many of you are live? Give me a thumbs up, each and every person. You got it? Can we go ahead? The next topic, the next question. So we are done with this topic. Okay, so this is nephritic. Read the properties. I told you. Read the examples. The most common causes are RPGN. Apart from that, PSGN is also there. Membranoproliferative is also there. These are both sides. These are the 6 properties of nephrotic. I told you: severe proteinuria, hypoalbuminemia, edema, lipidemia, lipiduria, and hypercoagulability. That is nephrotic. Here, 2 main causes are there. In children, it's MCD, and in adults, it's focal segmental glomerulosclerosis. Other causes are also there. Okay, so and the cause of edema is different in both of them. The cause of edema in nephritic, the cause of edema in nephrotic is hypoalbuminemia, and the cause of edema in nephritic is sodium water retention. Crystal clear concept. Why hypercoagulability, Sethi? It's a good question. I told you, the liver is compensating in nephrotic syndrome. So liver is making lipoproteins. So liver make one more protein, that is fibrinogen. So because of excess of fibrinogen, there is hypercoagulability. Okay, because of, again, it is due to compensation by the liver. So you can compare nephrotic syndrome. Coming on the next question very quickly. Read the question, tell me the answer. Read the question and tell me the answer. The question is based on rheumatic fever. How many of you know rheumatic fever? Read the question, tell me the answer. Antecedent diagnosis of group A streptococcal infection in acute rheumatic fever can be made by. So they are asking the Jones criteria. In the Jones criteria, we have 3 type of diagnosis. Major criteria, minor criteria, and supportive. The supportive one are the antecedent. Okay, so they are asking the supportive criteria. So is it ASO titer? Is it C-reactive protein? Is it ESR? Or is it C3 levels in the blood? So what is the correct answer? Yes, the correct answer is ASO. So it is not necessary every time. Let me change the question. Instead of antecedent diagnosis, let me ask you the minor criteria. Now what is your answer? If I ask you major criteria, now what is your answer? So basically, you must understand all the criteria in rheumatic fever. So can I start the disease rheumatic fever? Say yes. Can I start? So it is not necessarily you are getting. It's a previous year question. This question is already asked in the FMG, but it is not necessarily the same question will come. The question will be from the same topic, not the same question. So let me teach you everything, all important points about the rheumatic fever in the next 3 minutes. Let's start rheumatic fever. How many of you know what is rheumatic fever? How many of you know? Can I tell you? See here, listen. Rheumatic fever is a disease of children. It mainly occurs in children. So see, this is a child. Rheumatic fever, this is a child. The child is having tonsillitis or pharyngitis. What the child is having? The child is having tonsillitis or pharyngitis. You can see these are the tonsils of the child. The child is having tonsillitis or pharyngitis caused by a bacteria. The name of the bacteria is Group A Streptococcus bacteria. It is known as gas bacteria. Group A Streptococcus bacteria. This bacteria is the most common cause of tonsillitis or pharyngitis. So you say, ma'am, we also have multiple episodes of tonsillitis or pharyngitis since our childhood. We have many episodes. So what's that? We don't have rheumatic fever. How rheumatic fever is correlated with that? Listen. Now the body is making antibodies for the bacteria. Whenever we have a foreign body in our body, the body will make the antibodies. So these are the antibodies against the bacteria. What these antibodies will do? They will go bind with the bacteria, make an antigen antibody complex and destroy the bacteria. So how is rheumatic fever is occurring? The bacteria is destroyed. Bacteria do not cause rheumatic fever. Mind my words. Bacteria do not cause rheumatic fever. So who is causing actually the rheumatic fever? What is the problem? See what is the problem. Listen, on the surface of the bacteria, you can see inside the tonsils there is a bacteria. On the surface of the bacteria, there is an antigen. There is an antigen. Okay, the same antigen is present on human 5 organ. You can see human 5 organ. The same antigen is present on human 5 organ. So actually, the antibodies are formed for the bacteria for that antigen. But they will get confused. Antibody don't have eyes to see, oh, this is bacteria, this is my self tissue. Antibody will react wherever there is that antigen. This antibody is formed for this antigen for the bacteria. But the similar antigen is present on human 5 organs. So antibodies will react with the 5 organ and damage the 5 organ, producing 5 disease in 5 organ. So it is the own antibody. Body's own antibody is damaging own tissue. So it's an autoimmune disease. It's an autoimmune disease. So it is not the bacteria which is damaging the 5 organ. It is the own antibody which is damaging the 5 organ. So what are the 5 organ? The 2 vital, heart and brain. One is brain, one is heart. The 2 are vitals. I learned like this. The third is my skin. So one is heart. You can see one is brain, one is my skin. Below the skin, I'm having subcutaneous tissue. So the 4th one is subcutaneous tissue. And below that, I'm having joints. So this is the joints. So heart, brain, skin, subcutaneous tissue, and joint. Tell me the diseases in them. Tell me the diseases. So in the heart, there is carditis. In the brain, there is chorea. Okay. In the skin, there is erythema marginatum. In the subcutaneous tissue, it is subcutaneous nodules. And in the joints, it's arthritis. Polyarthritis, migrated polyarthritis. The 5 diseases together known as rheumatic fever. So basically, rheumatic fever is not one disease. It's a multi-system disease. It is involving 5 human systems. 5. And who is causing the disease? Is it bacteria? No, it is the antibodies. So yes, the mechanism is known as molecular mimicry. Absolutely right, Sethi. It's molecular mimicry. Who is doing mimicry? Who is doing mimicry with which one? So say, ma'am, the bacteria is doing mimicry with the human 5 tissue. So that is known as molecular mimicry and cross-reactivity. You got it? Now, Jones is a scientist. Jones is a scientist who has given the criteria to diagnose rheumatic fever. Hana? So this is known as revised Jones criteria, which are revised in 2016 onwards. So I'm telling you the revised Jones criteria. There are 3 types of criteria based on which our question is based right now. Major criteria, minor criteria, and gas. Gas is supportive criteria. That is group A streptococcal infection criteria. This is known as supportive criteria, also known as antecedent. That is our question right now. Antecedent criteria. Antecedent. Now listen. Now, what are the 5? So major criteria are 5. You can see the number. 1, 2, 3, 4, 5. Minor are only 4. And the supportive criteria are 3. So 5 plus 4 plus 3. Total, these are the criteria. What are the 5 major criteria? The 5 diseases. Can you see the 5 diseases? Say yes if you can see the 5 diseases. What are the 5 diseases? The 5 diseases and 5 organ. The 5 diseases. The 5 diseases in the 5 organ is the major criteria. So in the heart, it's carditis. In the joints, it's arthritis, polyarthritis. In the brain, it's chorea, Sandham's chorea. In the skin, multiple rashes are there. It is known as erythema marginatum. And in the subcutaneous tissue, multiple nodules are there. What should I elaborate here? Chorea. In the chorea, involuntary jerky movements are there in the air. It looks like the child is dancing, but actually the child is not dancing. The child is doing involuntary jerky movements in the air. That is chorea. The chorea is due to damage of basal ganglion in the brain. So that is the chorea. Okay, the 5 major criteria, the 5 diseases. What about minor criteria? Now, whenever we have tonsillitis, we have fever also. The fever is a minor criteria. Okay, the fever is a minor criteria. Arthritis is the major criteria, people. But arthralgia is minor criteria. See, arthritis, arthralgia, arthritis. Itis means inflammation. Inflammation of the joint is major. But algia means pain. Pain in the joint is minor. So, inflammation in the joint is major and pain in the joint is minor. Okay, whenever the heart is involved, carditis, so vegetations are formed on the walls, okay, because of which the patient have murmurs and because of which the ECG will be deranged. So in the ECG, increased PR interval is minor. So carditis is major, but because of which the increased PR interval in the ECG of the heart is minor. And apart from that, ESR and CRP are raised. ESR is also raised, CRP is also raised. So these are the 4 minor criteria. After that, the supportive criteria. Now you tell me, you are a pediatrician. You are a pediatrician, for example, and a child is coming to your clinic with the mother. The mother is saying that my child is having murmurs in the heart. I mean, the child is feeling lethargic. If you auscultate, you can hear the murmurs in the heart. The child is having multiple joint pain also. The child is having multiple rash also, erythema marginatum, multiple nodules. I mean, all 5 major are present. So the first question I will ask the mother, do the child have tonsillitis 2-3 weeks back? If the mother is saying, yes, my diagnosis is confirmed, the patient is having rheumatic fever because multi-system involvement is there. But if the mother is saying, no, my child is not having any tonsillitis episode in the last 2-3 weeks, what do? You have all 5 major, you have all minor, but this is absent. So we cannot say it is rheumatic fever. To say rheumatic fever, there should be a proof that this all red color stuff I have marked the circle. All 5 things are happening after tonsillitis. If it is without tonsillitis, I cannot say it's rheumatic fever. Say yes. So I have to prove the antecedent infection. That is known as supportive criteria. In the supportive criteria, I will prove there is an antecedent infection. So how to prove? Say the mother is saying, no, my child don't have any tonsillitis episode in the last 2-3 weeks. It's okay. Sometimes it's very minute. I mean, the child don't complain. Sometimes it's subclinical. So we will take a throat swab. We will take a throat swab and culture it, and we'll see whether the bacteria is growing or not. So take a throat swab, the first thing. It will be proven. Or else take the blood sample of a child in a test tube and look for the two type of antibodies against the bacteria. If the bacteria is present in the blood, body may have formed antibodies for that. So look for the antibodies. Okay, so you have to look 2 types of antibodies. Anti-streptolysin O titer, that is our question right now, ASO. Streptolysin OK against antibody, or anti-DNase antibody. Okay, so who will help me? The Jones criteria. Tell me 5 major criteria right now. Tell me the minor criteria, 4 criteria. Tell me 5 major, tell me 4 minor, and tell me 3 supportive, also known as antecedent criteria. So that is the question. You get many questions on that very frequently. Thank you so much for all your compliments, students. Thank you so much. Wishing you all the best in your personal life and your professional life. And you should be successful in every area of life. That is the only wish I want to give you. Okay, listen. So what are the 5 major criteria? Tell me. What are the 5 major criteria? Quickly. So in the heart, there is carditis. In the brain, there is syndrome scoria. On the skin, it is erythema marginatum. Just below the skin, there is subcutaneous nodules. And in the joints, it's arthritis. Arthritis, that is the inflammation of the joint. What are the minor criteria? Whenever heart is involved, it is major, carditis, but increased PR interval on ECG is minor. Arthritis is major, है ना? But arthralgia is minor. Arthralgia is minor. So 2 I am deriving from there only, and 2 I have to learn. Fever is a minor criteria, है ना? And increased ESR and increased CRP is minor. What about the supportive? We have 3 supportive criteria. What are that? So either take the throat swab. Either take the throat ka swab. है ना? Swab, है ना? Number 1. Or take the antibodies. 2 type of antibodies. Streptolysin O antibodies, anti-streptolysin O, and DNase antibodies. So anti-DNase antibodies. है ना? So these are the supportive criteria. Now read your question and tell me what they are asking. They are asking the antecedent criteria. Read the question carefully. They are not asking major or minor. They are asking you in the question, you can have a look, antecedent. Antecedent. So from the last 3, which is there? Is it ASO? Yes. Not CRP, not ESR, not C3. So correct answer is ASO. But if I change the question, instead of antecedent, if I ask you minor criteria, what is your answer now? If I'm asking minor, what is the answer from the same 4 options? Say CRP and ESR. These were coming in the minor, if you remember. So the answer will change. In that case, the answer will change. How many of you got it? Give me a thumbs up. Can I go to the next question? The next question is in front of you. Read the question and tell me the answer quickly. Read the question and tell me the answer quickly. Yes. Most characteristic finding for diabetic nephropathy. Tell me the most characteristic finding for diabetic nephropathy. So the question is about the diabetic nephropathy. I'm asking most characteristic. Is it Kimmelston-Wilson kidney or diffuse glomerulosclerosis? Is it focal segmental glomerulosclerosis or Armani-Ipsten change? So what is the answer if I ask most characteristic? And what is the answer if I ask most common? The answer will be different. Most common answer is different. Most characteristic answer is different. So most characteristic is Kimmelston-Wilson kidney and you all are right. But if I ask the most common, in that case answer is diffuse glomerulosclerosis. Let me explain you all about it. Hana? And if I ask you, tell me all the changes which occur in diabetic nephropathy. So of course A also occur, B also occur, and D also occur. Hana? Armani-Ipsten lesions also occur. So basically let me tell you all about diabetic nephropathy. Okay. Can I start? Diabetic nephropathy. What is diabetes mellitus? First you tell me. First, you tell me what is diabetes mellitus. Bhai, hota kya hai? So, diabetes mellitus is a disease in which glucose levels in the blood get increased. It is known as hyperglycemia. है ना? The glucose is more. There are 2 types of diabetes. Diabetes type 1 and type 2. In both of them, in the blood, the glucose is more. The normal range of fasting glucose is 80 to 100. But here, the patient is having more than 100. Okay? 100 to 125 is pre-diabetic and more than 126 onwards, it's diabetes. We know the criteria. Anyways, here the glucose is more. So, you will say, ma'am, what is the harm? If my blood have more glucose, what is the harm? Is it harmful? Yes. This glucose damages 3 organs in the body. Chronically, it damages kidney, it damages retina of the eye, and it damages the nerves, the peripheral nerves. When it damages the kidney, it is known as nephropathy, diabetic nephropathy. When it damages the eye in the retina, it is known as diabetic retinopathy. And when it damages the nerves, it is known as diabetic neuropathy. So currently, out of the 3, I am explaining 1, nephropathy. So let's start the topic diabetic nephropathy. Let's start the topic diabetic nephropathy. Diabetic nephropathy. So in diabetic nephropathy, I told you the glucose present in the blood, the more glucose, the extra glucose, that is damaging the kidney. So which thing in the kidney get destroyed? Which thing in the kidney get destroyed? So there are 2 types of presentation. Let me explain you. There are 2 types of presentation. You can see there are 2 types of glomerulosclerosis occurs. In some patient this occur, in some patient this occur. So see, this is diffuse glomerulosclerosis. And this is nodular. Let me explain why diffuse is known as diffuse. And let me explain why nodular is known as nodular. Let me explain this. There is diffuse glomerulosclerosis and there is nodular glomerulosclerosis. In both the glomerulosclerosis, listen, both occurs in the diabetes. Both can occur in type 1 also, both can occur in type 2 also. Diffuse is more common. More common. 80-90% this occur. But this one is more characteristic. more specific or more characteristic? So if the question is coming on more common, answer is diffuse. And if the question is coming on more characteristic or more specific pathognomatic, answer is nodular. There is one more name of nodular, that is known as Wilson kidney. But diffuse don't have any other name. You will say, what do you mean by diffuse and nodular? See, in both the diagrams, you can see a glomerulus. Can you see a glomerulus here? Say yes, you can see a glomerulus. Can you see a glomerulus here? Yes, you can see a glomerulus here also. In both the glomerulus, in diabetes, both occurs in diabetes. So in the diabetes, hyaline get deposited. The pink color acellular hyaline get deposited. So in the diffuse one, where it is deposited? It is deposited everywhere in the glomerulus at 4 places. It is deposited in the mesangium, you can see. It is deposited in the wall of the capillary. You see pink material in the wall of the capillary, number 2. So it is deposited in the mesangium. It is deposited in the wall of the capillary. You can see thickened glomerular basement membrane. Number 3, it is the cap of the capillary in the form of the cap. Can you see the pink color cap? Can you see pink color cap here? Can you see pink color cap? It is known as fibrin cap. The cap of a capillary ki jagah topi ki jaisa hai. And 4th one, it is deposited in Bowman's capsule. So everywhere it is pink color hyaline get deposited. That's why known as diffuse. Everywhere it is deposited. Don't learn the places. It is everywhere. It is everywhere. Got it? But in nodular, here also hyaline get deposited, but in the form of the concise nodules. It is not everywhere diffuse. No. It is in the form of the small nodules. You can see it is in the form of the concise small nodules are there. So you see here the hyaline get deposited everywhere. That's why it is known as diffuse. And here the hyaline get deposited concise in the form of the nodules. That's why known as nodular. This one is more common. This one is more specific. The second one is known as Wilson kidney. Say yes. How many of you got it? How many of you got it? So that is the thing. So there are 2 types of glomerulosclerosis, diffuse, nodular. This is more common. This is more specific. This one also known as KW kidney. KW kidney. Apart from that, one thing is common. So this one is more common, diffuse. Here the glomerulus hyaline is deposited in all the parts. That's why diffuse. And nodular is more pathognomatic or more specific. Here the hyaline is deposited only in the form of the nodules and it is known as KW, that is Wilson kidney. So I hope you all got it. Can I move to the next question? Say yes. I have not covered this lecture, Hassan, on the YouTube yet, but soon I will schedule it. Okay, can I go ahead? Say yes. So coming on the next question. Read the next question and tell me the answer. Most sensitive indicator for iron deficiency anemia. So my next question is based on iron deficiency anemia. Most sensitive indicator for iron deficiency anemia. Is it serum ferritin? Is it TIBC? Is it percentage saturation of transferrin? Or is it bone marrow iron? You tell me. First you tell me what is the correct answer. Yes, you all are right. The correct answer is the ferritin. And instead of most sensitive indicator, if I ask you who's the transporter? What is the answer in that case? In iron deficiency anemia? What is the answer? So let me explain you all about iron deficiency anemia. I will come on the question again. Currently answer is ferritin. Let me explain you. Iron deficiency anemia. You frequently get question on this topic. So we are covering the topic, people. We are not covering the question. We are covering that topic completely. By iron deficiency anemia, any question coming, you are prepared. So let's start iron deficiency anemia. Can I start iron deficiency anemia? Listen, this is the digestive tract of a normal human being. For example, this is my digestive tract. Okay. Now here, listen, I'm eating iron. We all eat iron in our diet. Whatever diet you eat, it contains a little bit of iron. Whether you eat vegetarian diet, whether you eat non-vegetarian diet, whatever diet you are eating, it contains iron. So whatever iron we are eating, the iron is going inside. So problem is that whatever iron we eat, it is in ferric form. In veg also, in non-veg also, it's ferric. So it will go inside, it will reach the intestine. Now I want the intestinal cell should absorb it. So can you see this cell? This cell is intestinal cell. Can you see this cell? This is the cell. Can you see this is the cell? This cell is intestinal cell. Can you see this is intestinal cell? So this cell is intestinal cell. I want the iron. Now on one side of the cell there is lumen of the intestine, and on other side there is a blood capillary. There is a blood. So I want the intestinal blood vessel. I want the iron to get absorbed. You see, iron should get absorbed, go inside the cell and come on the other side and reach the blood. So this is what absorption is. So we eat anything, it will go in the lumen of the intestine, it get absorbed and go in the blood. So it requires 2 transporter. One on this side, one on that side. So one on luminal side, one on basolateral side. So you can see the 2 transporters. Let me highlight. So this is the first transporter I am talking about here. It takes iron from the lumen into the cell. And this transporter is known as divalent metal transporter, DMT. And the second transporter here on the basolateral side, it takes the iron from the cell into the blood. This transporter is known as ferroportin. So we have two transporters, DMT and ferroportin. The problem is with DMT. What is the full form of DMT? DMT का full form क्या है? What is the full form of DMT? Divalent metallic transporter. DMT, divalent. So it takes only 2 positive charge. The ions which have 2 positive charge, not 3 positive. It takes only the ions which is having 2 positive charge. But whatever iron we are eating is ferric. So it will not absorb. It will. So if you want to get absorbed, first convert into ferrous. So whenever we eat iron, the iron goes in the stomach. In the stomach, we have HCl. HCl convert the ferric iron to ferrous iron. You can see this job is done by the HCl. So HCl convert ferric iron into ferrous iron, and after this conversion, the iron is coming in the lumen of the intestine. Now DMT can absorb it. So DMT will absorb this iron, and this iron will go in the blood, and from the blood it will go to the ferroportin. Ferroportin will transport it into the lumen of the into the capillary. But during this transport from the ferroportin, it will again oxidize from ferrous to ferric. So whatever we eat is ferric, whatever reaches the blood finally is ferric. Only for absorption purpose it convert into ferrous. Give me a thumbs up how many of you got it. So this is the absorption of the iron. You get questions on ferrous, ferric, and please understand HCl is required for absorption. More is the acid, more is the absorption, because the acid, not only HCl, all the acid convert the iron from ferric to ferrous, and it helps in absorption of the iron. Alkali reduces absorption. Acid increase absorption. The general rule. More is the acid, more is the absorption of iron. More is the base or alkali, less will be the absorption. You know the reason why, right? Now finally iron reaches in the blood, but iron don't walk. Iron need a scooter on which the iron will sit, and the scooter will take the iron here and there. I call the scooter as transporter. So can you see this is the scooter I have drawn? In this diagram, you can see this is the scooter. This is the scooter. This is the scooter. This is known as transporter of iron. It is known as transferrin. So transferrin is the scooter of iron on which the iron travel. Why I'm not calling car? I'm saying only scooter, because in the scooter, 2 people can sit at a time. So one transporter carry 2 iron at a time. You should draw 2 here. One transporter on one transferrin, 2 iron ke molecules are traveling here and there. That's why I call it, insist you to call it a scooter. So transferrin is the transporter. Transferrin is the transporter of iron. Transferrin is the transporter of iron. Hai So you can learn T40. Got it? Now where iron is required in entire body? In entire body, we want iron only in one organ. What is that organ? Bone marrow. Inside the bone marrow, 3 cells are formed. RBC, WBC, platelet. We want iron for RBC, not for WBC platelet. Inside the RBC, we have hemoglobin. So we want iron for heme, not globin. So we have bone marrow, inside which RBC are synthesized. These are the precursors of the RBC, inside which for the synthesis of heme, we require iron. So all the iron which is required here, it's given to the bone marrow. These cells will pick it up, Whatever extra iron is there, it is shunted towards the liver. Now in the liver, the extra iron is stored. So it is stored in the form of the ferritin. This iron is stored in the form of the ferritin. So can I say ferritin is the storage form of iron? Yes. So ferritin is the storage form of iron. The transporter of iron is transferrin, and the storage form of iron is ferritin. How many of you got it, people? The storage form is ferritin. Okay. So the complete story is like this. Let me tell you about the hepcidin. Okay, listen. Now when this storage is too high, when the ferritin content in the liver is too high, what will happen when the ferritin content? So iron is toxic. To some limit, the liver will store it. But after that, liver do not want to store it. So what the liver will do? Liver will synthesize a molecule, a protein, the name of which is hepcidin, and release it into the blood. So hepcidin will go via blood, reaches in the intestine and destroy the ferroportin. This hepcidin will come in the blood only when iron is too high. The ferritin is too high in the liver. Then only it will come in the blood. So ferroportin is destroyed now. Now whatever iron you are eating, the person is eating, it will not absorb. It will lost in the feces. So body will take only that iron that is required. The extra iron is lost. So first the iron taken which is utilized here, and then the extra iron is stored. Uske baad bhi kuch hai, so it is excreted. When the ferritin concentration is low, storage is low, liver stops synthesizing hepcidin. So ferroportin is again activated and absorption start. So I can say hepcidin is the regulator of iron. It is the regulator of the iron. So when iron store is high, hepcidin come in the blood and it reduces the absorption. Because iron is already high, we don't need that. And when the iron store is less, hepcidin synthesis is less. and the absorption will be more because ferroportin is again regenerated. How many of you got it? So let me ask you 3 questions. Who is the transporter of iron? Who is the storage form of iron? And who is the regulator of iron absorption? 3 questions and 3 answers. So transporter of iron is T for T. It's known as transferrin. Okay, G. What is the storage of iron? It's ferritin. Iron is stored in the form of the ferritin. And regulator of iron is hepcidin. Hepcidin is the regulator of iron. Say yes if you got it. Hepcidin is the regulator of iron. So that is the story till now. Now imagine if from today, I'm not eating iron in my diet. The reason can be multiple. I'm not aware that my diet is poor of iron. Maybe I'm too old and I don't have dentation. I cannot eat properly. Maybe I'm very sick and I'm not eating since month. I'm having a disease and I'm unable to eat. And maybe due to the fasting purpose, some religious taboos, due to anything. Due to anything, I'm not eating iron in my diet. The reasons can be multiple. Okay. Or else I'm eating, but my intestine is not able to absorb it. So what will happen? So ma'am, it's okay now. If you don't eat, it's okay. You have the backup. This is the backup. You have the backup. The backup is in the form of the ferritin. You already have the ferritin in your liver. That will give the backup for 2 to 3 months. If you don't eat iron for the next 2 months, it's okay. You will not have anemia. So this ferritin, ultimately iron is required here for the synthesis of heme in the bone marrow. So if it is coming from the intestine, it's good. But if it's not coming in the intestine, it's okay. Liver will give it. Liver says, it's okay, I'm there. I will give you the backup. So ferritin is the first thing which will fall. That is our question right now, the most sensitive indicator of iron deficiency anemia. So whenever we have iron deficiency, the first thing which falls is ferritin. So ferritin will fall. It will give the backup. One point will come, the ferritin will become 0. Now there is no backup. Now after that, the RBCs which are synthesized will have less iron and it is known as iron deficiency anemia. Hemoglobin will fall. So before the person's hemoglobin fall, before the persons have any symptoms, before that ferritin fall. So if I want to know whether a person is having iron deficiency anemia or not, I should not check the hemoglobin. I should check the ferritin. If hemoglobin is normal and ferritin is low, the patient is going to have iron deficiency anemia in the next few months. He's already started. So the most sensitive indicator is not hemoglobin. No, the most sensitive indicator is ferritin. This is the meaning. And the earliest indicator is also ferritin. So whether they ask you the earliest indicator, answer is ferritin. Whether they ask you the most sensitive indicator is ferritin. Whether they ask you the best indicator, it's ferritin. Because it is the first thing which is going to fall. And after that, everything else will fall. So this is the backup. How many of you got it, people? Kitno ko samajh mein aaya? One more thing I would like to tell you here, on which frequently questions are asked. You got it, ferritin. The most sensitive indicator of iron deficiency anemia is ferritin. What is TIBC? Kya hota hai? Tell me the full form of TIBC. What is TIBC? TIBC is transferrin iron binding capacity. What do you mean by that? Let me clear you this concept also. Acha, who's the scooter? Where is the scooter? To whom I call the scooter? Just now I taught you, who is the scooter of iron? That is the transporter of iron. That is transferrin. So you can see where is the scooter. Let me show you. So in the blood vessel, the iron do not walk by itself. The iron sit on a scooter and the scooter is carrying the iron from here and there. So this is transferrin. Transferrin is measured in terms of percentage. By percentage, I mean 100. For example, I call them scooter. I'm having 100 scooters in my blood. For example. So these are the 100 transferrin molecules, 100 scooters in my blood. For example, I'm having. So at a time, only 33 of them are filled. They are saturated. They have iron on them. Okay. And 66 of them are empty. It is normal in me, in you, in healthy individuals. It's like that. Let me draw. So this is a scooter. This is a scooter. So one scooter carry 2 molecules of iron. So this one is filled. I call it, this one is filled and this one is empty. So at a time, 33 are filled and 66 are empty. You can see this one is empty. Iron is not sitting there. This one is empty. This is normal. This is normal. You tell me this is normal. So the filled one is known as transferrin saturation. What it is known as? They are saturated. Naam mein uska meaning hai. The meaning is hidden in the name. It's saturated. That's why transferrin saturation. But the empty one are known as TIBC. What is the full form of TIBC, you say? What is the full form of TIBC? Transferrin iron binding capacity. That is a capacity. You say कि मेरी capacity इतनी है. मैं कहती हूँ मेरी capacity तो 10 घंटे पढ़ाने की है. मतलब मैं पढ़ा सकती हूँ पर मैंने किया नहीं है आज तक. But I am having the capacity to do so. So we say ना कि मैं तो 10 घंटे पढ़ सकता हूँ. मैं तो ये कर. So that is a capacity. Capacity. Capacity is the thing we can do in future. We are capable of doing that. But we have not yet done that. But we are capable. So that is the capacity. So capacity means we can take 66 more molecules. We are empty. So that is TIBC. So this is normal. So say ma'am, in a normal individual, the transferrin transferrin saturation is 33%, but the TIBC is 66%. This is normal. This distribution is known as normal distribution, normal split in a normal healthy individual. What happened in iron deficiency anemia? You use your common sense, you use your brain and tell me what happens in iron deficiency anemia. In iron deficiency anemia, the natural iron is less. Na? The person is not eating the iron. Iron is come. So this will fall, but the empty one will be more. Hai the filled one will fall and empty one will be more. So basically in iron deficiency anemia, the transferrin saturation is less and TIBC is more. No need to learn. If you have understood it, no need to learn. Give me a thumbs up if you got it. So this is also a question which is coming in your exam. So these are the all questions which they ask on iron deficiency anemia. They can ask you, who's the transporter? You know the answer. Who's the storage form? You know the answer. You know the regulator of the iron? You know the iron answer. And they can ask you in iron deficiency anemia, what happened to transferrin saturation? What happened to TIBC? Which one is increasing? Which one is decreasing? What happens to ferritin? So of course, ferritin will fall, saturation will fall, but TIBC will rise. And the best or the earliest or most sensitive indicator is ferritin. How many of you got it? How many of you got it? Say yes if you got it. Say yes if you all got it. Okay. Is there a lag behind? Is there a lag going on? Someone is writing that it is lagging. It is lagging. So I can't help if it is lagging. Anyways, so is it lagging completely or there is a asynchronicity in the video and audio? What do you mean by the lag? No lag. Okay. So, okay, there may be problem with the person who is saying the internet connection. Okay. So what are the clinical features of iron deficiency anemia? So person will have weakness, fatigue. These are general, but 3 specific features which occur in iron deficiency anemia. You get image-based questions on that. Listen, the nails will become spoon-shaped. Have you seen a spoon? Chammach ke jaisa. The spoon, the nails become spoon-shaped. It is known as spooning of the nails. This is known as koilonychia. Koilonychia. Nychia means nails and koilo matlab spooning. The nails become spoon shaped. It's very common. It's very common. The tongue become atrophied. See a normal tongue, it's shiny, healthy. See your tongue, it's shiny, healthy. But in iron deficiency anemia, it's atrophied. Okay. And the mouth, at the angles of the mouth, you can see angular stomatitis. At the angles of the mouth, it's angular stomatitis. Got it? Got it? Say yes if you got it. That is the epithelial changes you can see. Okay. Okay. So that is the thing. And here I told you, you can see this is the filled one. This is the empty one. The scooters. Each scooter is carrying 2 molecule of iron. The filled one is known as transferrin saturation and the empty one is known as TIBC. So I told you in iron deficiency anemia, the filled one will decrease and the empty one will increase. This one normally is 33%, but it will be less than 33% in iron deficiency anemia. This one normally is 66. It will be more than 66 in iron deficiency anemia. I told you this completely. Let's come on the next question. Can I start the next question, people? Are you ready? Can I start the next question? How many of you are enjoying learning, understanding the concepts? So you want me to teach you only question, answer, or you want this way that topic should be completed, ma'am? The question was simply on ferritin, but I taught you everything. Not only ferritin, I taught you transferrin also. I taught you hepcidin also. I taught you the clinical features also. I taught you the presentation also. And a lab diagnosis also. I taught you everything. So it is not the thing, the same question. It is a topic. So concentrate on topic. So the 50 questions are important. No. Understand the 50 topics completely and you are in. All the questions will be from those 50 topics only, but you have to understand the topics. Okay, so can we continue with the same way? Thank you so much. We will do in the same way. Listen, read the next question. It's a difficult level question, very difficult level question, I must say. Read the question and tell me the answer first. Rolling of WBC, leukocytes at WBC, है ना? On the endothelial cells is mediated by, is it selectin, is it integrin, is it transferrin, or is it PCAM? What is the correct answer? What is the correct answer? ABCD. You tell me what is the correct answer. Yes, the correct answer is the selectin. Absolutely right. So let me explain you. What if I change the question instead of rolling, I ask you adhesion? The answer will change. Huh? What if I, instead of adhesion, I ask you diabetes? From the same 4 option. What is the answer? The answer again change. So let me explain you all the things. The rolling, the adhesion, the diabetes. Let me explain you everything. Okay. I will come on the question again. Let me give you the concept. Okay, so in acute inflammation, we have 2 type of events, vascular events and cellular events. So there are 5 vascular and 6 cellular. So 5 plus 6, total 11 events are there in acute inflammation. In acute inflammation, we are having 11 events, the 5 vascular and the 6 cellular. Total 11 events are there in acute inflammation. Got it? Now please understand, I'm not teaching you vascular events currently, the 5 vascular. I'm directly teaching you the 6 cellular. In the vascular events, I'm telling you the summary. The summary of the 5 vascular events. You can see a blood vessel. Now see, please understand this master diagram. If you understand, you may be thinking, ma'am, why all these 11 events you are taking? Anna, what is the need? Why? So please understand this master diagram. Can you see a blood vessel? Yes. Now can you see a microbe? I call the microbe as terrorist. I call it a terrorist. Terrorist is someone who is entering in the country's territory and harming the country people. The terrorist is a foreign particle. So in the same way, this microbe can be bacteria, can be virus, can be fungus, can be parasite. It's a foreign particle. It enters in human body and causes, diseases in human body. So I will compare it with the terrorist. Don't worry, now God has provided us the army. Who's our army? The army. The army is the WBC. We have soldiers in the army. There are two types of soldiers, B lymphocyte and T lymphocyte. So this is the lymphocytes, the soldiers in our army. है ना? So what is happening now actually, whenever the terrorist is entering, the terrorist want to do the infection, and the army want to oppose it. That is known as inflammation. The army want to oppose it. That is known as inflammation. So I want to make a fight between the terrorist and the army. Let's see who is winning. If the terrorist is winning, person will have infection. If the army will win, the person have inflammation. So let them fight and let's see if you have a strong immunity. बोलते हैं ना मेरी immunity तो strong है, मुझे कुछ नहीं होगा. So if you have a strong immunity, you will have inflammation. You will not have infection. But if you have a weak immunity, you will have infection. So there is a fight between the terrorist and the army. You will say, ma'am, then what is the problem? Let them fight now. Let them fight. What is the problem? The problem is that one is extravascular, one is intravascular. You can see the microbe is present outside the blood vessel. Can you see where is the microbe? It's outside the blood vessel. And where is the army? The army is inside the blood vessel. How they can fight with each other if they can't meet? You have to meet them. So how they will meet? Say, ma'am, there are two possibilities. Either take the microbe inside. No, it's a bad choice. If you take the microbe inside, it will go in the blood and spread everywhere in the body via blood vessel from head to toe. We cannot afford that. The person will have sepsis. We cannot afford that. Rather than do vice versa. Take the army out. Don't take the terrorist inside. Take the army out. Hana? So let them fight after that. So the complete 11 events are done. All the 11 to take the WBC out. I want to take the WBC out. That's why I want to perform these 11 events. In the first 5 events, we have already created a gap in the wall of the blood vessel. The blood vessel is continuous. Now from where it will go? So this is a gap. We have already created it. Now I want to take the WBC out of this gap. I require 6 steps. The 6 cellular steps. Let me tell you what are the 6 steps. You got this diagram? Give me a thumbs up if you got it. So let me tell you the six events, the 6 cellular events. Listen. Now have you heard about the Bernoulli's theorem in physics? So let me apply the Bernoulli's theorem here. Yes, थोड़ा सा physics पढ़ लेते हैं. In the physics, we have read the Bernoulli's theorem. The Bernoulli's theorem says that the heavy portion in a fluid travels at the center and the light portion travels at the periphery. Now, let's say the blood vessel is a pipe only. It's a hollow vessel. Okay. Now, there are 4 things in the blood vessel. RBC, WBC, platelet and plasma. So, who is the heaviest? Who is the heaviest? WBC is the heaviest. WBC is the heaviest. It travels at the center. The WBC is the heaviest. Okay. What, ma'am, please tell this one. Yes, I'm telling you now. So WBC travels at the center. Okay. And the lighter things travels at the periphery. So RBC travels at the periphery like this. RBC travels at the periphery like this. Hana? And platelets are more lighter. So platelets travel like this, more periphery. And last thing is plasma. So plasma is the lightest one which is present at the most periphery. This is the distribution. Now this is my gap. You can see this is my gap. Here is the gap. I want to take WBC out. The problem is that the thing you want to take out, it is at the center. It was easy if WBC was present at the periphery, I can easily take it out. No, but I cannot take it right now, no? Because it is not at the periphery, it is at the center. So it cannot directly jump from the center. So first you have to take the WBC from the center to the periphery and then you can take it out. You got my point, Hana? This flow is known as axial blood flow. Normal blood flow in me, in you, it is axial. In the axial, the WBC at the center. So I have to make it reverse axial. First, I have to make it reverse axial. In reverse axial, I have to take the WBC from the center to the periphery. That is, I have to make it reverse axial. How many of you got it? So these are the 6 events. I will show you all 6 in one diagram to explain you the question. Listen, everyone on the screen. Everyone on the screen. Can you see the diagram? In this diagram, can you see a WBC? This WBC is at the center. See, the WBC is at the center. The first thing, WBC leave the center and come at the periphery. This step is known as margination. Because the WBC is coming at the margin. The first step, there are 6 events. The first thing is the margination. WBC leave the center and come at the periphery. That is axial blood flow convert into reverse axial. So axial convert into reverse axial. पहली चीज तो हो गई जी, है ना? Now the gap is not immediate, people. Gap थोड़ा आगे है. Gap is little bit ahead. So WBC don't have foot like us, don't have legs like us, WBC walking and going there. No, WBC don't have foot. So how WBC will reach from here to gap? With the help of rolling. Have you seen the tire rolling on a road? Imagine this is a road. Imagine there is a tire. I don't have a tire right now. Let's use the cap. Okay, let's use this cap. So imagine this is a tire, this is a road. So you can see the tire is rolling on a road. So in the same way here, you can see this is the WBC. It is rolling and reaching towards the gap. Okay, so the second step is the rolling. The second step is rolling. Just before the gap, it stops. So stoppage is known as adhesion. So first we have margination. WBC leave the center and come at the periphery, then rolling. Then just before the gap, it stops. That is adhesion. After that, the most important step, diapedesis. The most important step, diapedesis or transmigration, one and the same thing. Diapedesis, that is WBC come from intravascular to extravascular. WBC comes out. This step is known as diapedesis or transmigration. After that, now WBC don't have eyes. This side bacteria, this side bacteria. Where is the terrorist? I have to move the, not the three-dimensional space. WBC move here or here or here or here or here or back. Where should WBC should move? So who will tell you WBC ki you come here, not go there? So actually it is the bacteria. It will secrete certain chemicals and those chemicals will attract the WBC. The terrorist is secreting the chemical. Oh, come here, soldiers, come here, I'm here, just come and fight with me. So the movement is towards chemical. So the fifth step is chemotaxis. Chemotaxis is the, you know what is taxi? Taxi matlab movement. Okay, chemo matlab chemical oriented. So it's a chemical oriented movement. It is known as chemotaxis. And finally, the last step is phagocytosis. The WBC will engulf the bacteria. Engulf the bacteria, the story is over. That is known as phagocytosis. So first you tell me the sixth step. Close your eyes and tell me the six steps. Say, ma'am, first thing is margination. WBC leave the center, come at the periphery, then rolling, then adhesion, then diapedesis, then chemotaxis, and finally phagocytosis. Give me a thumbs up. How many of you got it? You people don't respond. Come on, be fast. Huh? Give a gesture that you got it. The six steps. The six steps. Now, I want to explain you three among them in detail right now. Margination, nothing important. I told you, leaving the center, coming to the periphery, that's it. How does rolling occur? Tell me. How does adhesion occur? Tell me. And how does transmigration occur? Tell me. I'm interested in these three right now. How does these three steps occur? You are getting my point. So I told you, now rolling. Now just suppose this is the road. Who's the road? The endothelium. And who's the tire? The tire is the WBC. So the tire is rolling on the road. So can you see on the surface of the tire, there are receptors. On the surface of the road also, there are receptors. They form a bond with each other. Hai na? The bonds are very transient. They just form, they break, then again move. They just form, they break, then again move. They just form, they break. So bonds are transient. So between the receptor here and receptor here, the bonds are formed, which are transient. Bonds form, bonds break, a little bit move. Bond form, bond break, then move. So in this way, the rolling is occurring. Just before the gap, the bonds are firmer. It will not move further. It will stop. So again, the bonds are there. And transmigration is also with the help of bond. So I want to tell you the corresponding receptor between the road and the tire. I will call the endothelium as road. I will call the WBC as a tire. So there are 6 pairs you have to learn. You cannot change the pair. So whatever receptor present here, the corresponding receptor present here, so it's a pair. It's a pair. The first pair, the second pair, the third pair. You have to learn the name of the 6 pairs. The 6 pairs are in front of you. And now the 6 pairs are in front of you. See, I have drawn a diagram. Rather than reading this, draw it in a diagram. So can you see this is the road? The road is the endothelium. Okay. And the tire is the WBC. So let's say the first pair, on the road, we have 2 selectin, P-selectin and E-selectin. Let's say this is P-selectin. Let's say this is E-selectin. They form bond with the tire. On the tire, the corresponding molecule which form bond with these 2 selectin is silyl-Lewis-X. 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 So the 2 pairs are in front of you. In the first pair, it's P-selectin with silyl-Lewis-X. In the second pair, it's L-selectin with silyl-Lewis-X. You have to learn what is present on the road, what is present on the tire. Among this pair, the selectins are on the road and the silyl-Lewis-X is on the tire. Total, there are 3 selectin. How many selectins are there? Total 3 selectins are there. Dekho, the first P-selectin and E-selectin, these 2 are present on the road. But the third selectin is L. L for leukocyte. L-selectin is present on the tire. And it form a bond with the corresponding glycam. Glycam से मुझे याद आता है 2 बड़े भाई. Glycam के 2 बड़े भाई हैं. ICAM and VCAM. This is ICAM and this is VCAM. So ICAM and VCAM, they form bonds with the integrin. Beta 2 integrin and beta 1 integrin. Okay, and the last pair, the 6th one, You can see this is road, this is tire. So same molecule is present both the side. So on both sides, this also and this also. The last molecule, it is pCAM. pCAM is present. Only one which is present on both sides. pCAM, CD31 or pCAM. You have to learn these 6 pairs. Say yes if you got it. You have to learn it anyways. Hana? pCAM and pCAM. The same thing is written in front of you. See the 6 pairs in front of you. The last pair is same on the road and the tire. Now in each pair, you have to learn what is present on the road, what is present on the tire. What is present on the road, what is present. So just suppose this is the road, that is endothelium, and this is the tire, that is WBC. So on the road, we have P-selectin or E-selectin. Here we have silyl that forms a bond here. Hana? This is how you have to continue with the 6 layers, 6 type of pairs. Say yes if you all got it. Say yes. Now please learn. The first pair and second pair is responsible for rolling. This is for rolling. I'm sorry. First and third. By mistake I said. The first and the third pair is responsible for rolling. The first and third is responsible for rolling. The fourth and fifth is responsible for adhesion. Fourth and fifth, both are responsible. If you don't change the sequence, things are simple. If you change the same sequence, then you will get confused. The fourth and fifth is responsible for adhesion. The second pair is responsible for both rolling plus adhesion. You get question on that. So rolling plus adhesion, both comes in E-selectin. Only rolling, it's P-selectin and L-selectin. Only rolling wala. Rolling plus adhesion, both is E-selectin. And both the integrin wala pair is responsible for adhesion. And the last 6th pair is responsible for diabetes. This step is, you can see now it's for diabetes. The WBC is coming out in the diagram also you can see. So pCAM is responsible for diabetes. People, how many of you got it? Say now. So same thing is written. The first and the third pair is for rolling. The fourth and fifth for adhesion. The last one is for diabetes. But the second pair is for both. You want to draw it with me? We will draw it once. Hannah, can you help me please? I'm requesting. Tell me the 6 receptors on the road. I mean the endothelium. Hannah, I feel easy to call it a road. And tell me the 6 corresponding receptors on the tire. I mean the WBC. I feel easy to call it a tire. And tell me the function. Hannah, which pair is responsible for what? Hannah, tell me the 6 pairs completely. Can you please help me? Requesting. Chalo. The first and second pair. 1, 2, 3, 4, 5, 6. The first and second pair is very easy. P-selectin, E-selectin, and third is L-selectin. But L is for leukocyte. It is present on the tire. So this is the 3-selectin, how I learn. So P and E-selectin form a bond with, this form bond with silyl X. This also form bond with silyl X. This is how I learn. But what about the L-selectin? It form bond with glycam. Just say I write glycam. As soon as I write glycam, I remember it's 2 big brother. Glycam के 2 बड़े भाई हैं. I-cam and V-cam. मुझे साथ में याद आते हैं. I call all these cam brothers. So glycam, I-cam, V-cam. I-cam and V-cam, they form bond with integrin. है ना? I-cam form bond with beta-2 integrin and V-cam form bond with beta-1 integrin. The last pair is super simple. Everyone knows. P-cam with P-cam. The last is P-cam with pCAM. Don't forget to learn the other name of pCAM on which you get question. तुम pCAM learn करके जाओगे, option में आ जाएगा CD31 and you don't know pCAM is only CD31. So learn the other name also, CD31 with CD31. Whatever coming in your option, you will be able to identify it. Now tell me the functions. Chalo, start saying. The first pair, rolling. The third pair, rolling. The fourth and fifth, both the integrin. Fourth and fifth, adhesion. है ना? The second pair is rolling plus adhesion. That is E-selectin wala pair. And the last one, pCAM, it's diabetes. Now, this is the gist of the story. I have drawn this diagram, explained you super well. Now coming on your question. Let me ask you the question. Let me ask. They are asking for rolling. I mean, they are asking for rolling. Read. Come. They are asking for rolling. They are asking for first and third pair. They are asking for the first pair. What is the first pair? P-selectin wala. And the third pair, L-selectin wala. So my answer is selectin. Rolling ke liye selectins are responsible. Okay. And if correct answer is A. But if I change the question to adhesion, instead of rolling, if I ask you adhesion means I am asking the fourth and the fifth pair. So in that case, my answer is integrin, beta-2 and beta-1. And instead of that, if I ask you the question diapedesis or transmigration, I'm asking the last pair. So my answer is pCAM with pCAM. So questions are super simple if you understand the concept. Say, how many of you got it? Don't change the sequence. It will be like, cakewalk for you. Everyone give me a thumbs up, people. Respond. Keep interacting. Anna, you can see my face. You can see my smile. You can see my expressions. Anna, it's easy for you to grasp. But imagine I'm having a system in front of you and this chat box. That's it. I can't see you. I wish if I could see you all. I can see the expressions. Anna, whether you got it or you didn't got it. So that's why I have to ask again and again, you got it or you didn't got it. Write down. Anyways, chalo, move further. The next question, the next topic. Chalo. The next question, the next topic. Stellate shaped granuloma is seen in which disease? Very frequently asked question. They are asking stellate. What do you mean by stellate? Stellate is star, a beautiful star. So tell me a granuloma which is star shaped. In which disease it occur? Is it sarcoidosis? Is it cat scratch? Is it Crohn's disease? Or is it tuberculosis? So who will tell me? What's the correct answer? Yes, absolutely right. The correct answer is the cat scratch. So it is not only this question. We will study complete granuloma. So let's start the next topic, granuloma. Granuloma. How does a granuloma is formed? Granuloma is type 4 hypersensitivity or delayed hypersensitivity. How does it form? Let me draw a granuloma for you. The steps of formation of granuloma. You see, this is the antigen. Okay, this antigen is non-degradable. You see, this is an antigen and this antigen is non-degradable. Okay, this is a non-degradable antigen. So this is antigen presenting cell. The first cell, it is, give me some example of non-degradable antigen. For example, Mycobacterium tuberculosis, Mycobacterium leprae, these all are non-degradable antigen. So when they enter in human body, the first cell they interact is antigen presenting cell. The antigen presenting cell will engulf it. The antigen presenting cell will engulf it, try to degrade it, but unable to degrade it because it is non-degradable. So it will get scared that what to do now. APC got scared कि ये तो degrade नहीं हो रहा है. I'm unable to degrade it. What to do? So it will carry to the next cell. Who's the next cell? Who's the next cell? The next cell is helper TH1. CD4 lymphocyte, CD4 T lymphocyte, helper TH1. Helper TH1 cell, and it will give signal to this cell that I got an antigen that is non-degradable. I'm unable to degrade it. What to do now? So it will say it's okay. Don't get panic. I will take care. है ना? So it will secrete on getting stimulation. This helper TH1 cell, it will secrete 3 cytokines from that. It will secrete 3 cytokines from that. You have to learn the name of the 3 cytokines. The first is interferon gamma. The second is interleukin, and third is TNF. You have to learn interferon gamma, interleukin, and TNF. What does they do? They will take one cell from the blood vessel out and make a granuloma. So which cell, which one is taking which cell? So let's talk about interferon gamma, the most important. Interferon gamma takes monocyte out. In the blood we have monocytes. Now, interferon gamma takes it out. Interferon gamma is taking them out. Monocytes are coming here. Monocytes, they not only take monocytes out. Once the monocyte is out, it is known as macrophage. Now I will not call it monocyte, I will call it macrophage. This cell is macrophage. After that, they modify the macrophage. They make it large, the nucleus is vesicular. They modify the macrophage. The modified macrophage is known as epithelioid cell. So this will become epithelioid cell. Now multiple epithelioid cell fuses with each other and it will form a giant cells. And a multinucleated giant cells. So first macrophages are formed, then epithelioid cells, then giant cells. And this complete thing is done by interferon gamma. Now the second cell, the second interleukin, cytokine is interleukin. It will take T lymphocytes out. T lymphocytes will come and accumulate here. And the third one, TNF, it will take the fibroblast out. Fibroblast will come and accumulate here. So finally, I'm having 3 type of cell. They will make a granuloma. The center of the granuloma is formed by this, the middle zone by this, and outermost zone by this. On the next page, I'm drawing a granuloma for you. So at the center, we are having epithelioid cells. We are having the epithelioid cells at the center. Few of them fuse together and they form the giant cell. Ikka dukka. We have few giant cells. The middle zone is formed by the T lymphocytes. This is T lymphocytes. And outermost zone is formed by fibroblast. Outermost zone is formed by fibroblast. Okay, this is a typical granuloma. Fibroblast will form the collagen and there is a fibrosis at the outer side. This is a typical diagram of granuloma. Give me a thumbs up. Granuloma don't contain neutrophil. Granuloma contain these 3 type of cell. Can you tell me the source? Epithelioid cells. Epithelioid cells. Epithelioid cells are derived because of interferon gamma. You get question on that. T lymphocytes are derived by interleukins and fibroblasts are derived by TNF. And ultimately a granuloma is there in front of you. Say yes, people. Thank you so much. Thank you for your compliment. Subhashri. So you people only give me the energy. You people are constantly interacting and you are at this late hour also. You are ready to study for me. Why not I? Why not I should be ready to teach you? Okay, so listen. So this is a diagram of a typical granuloma. Please understand granuloma don't have neutrophils and that. This is a typical granuloma. So the steps are in front of you. But I will tell you a special granuloma now. So these are the 3 steps. So the same diagram in front of you, appreciate the granuloma. See the center, you can see these cells. These all cells are epithelioid cells. This is a giant cell. See the middle zone. These all are T lymphocytes. And see the outermost. Outermost is the fibroblast. This is all fibroblast. The outermost is the fibroblast. Okay, chalo. So the same steps, I'm not reading the steps, I have explained you. The first macrophage is coming, trying to degrade it, unable to degrade it. So macrophage will fail to degrade it, it gets scared and it will present it to the next cell, helper Th1 CD4 lymphocyte. It will secrete 3 cytokines, interleukin, interferon and TNF. Okay, so all these, interferon gamma will take the macrophage out, interleukin will take the T lymphocyte, and TNF will take the fibroblast, and they will make a granuloma. A beautiful granuloma in front of you, which don't have neutrophil. But there is a special granuloma, which is our question right now, that is stellate granuloma. Stellate granuloma is a special granuloma in which the center have the neutrophil. Normally neutrophils are not there, but here at the center, we have the neutrophils. The core is neutrophil, and it is star-shaped. Since it is star-shaped, that's why it is known as stellate. Appreciate the boundaries of the star here. Can you see the boundaries? They are looking like a star. So the star-shaped granuloma is known as stellate granuloma. It is seen only in 2 diseases. You have to learn the examples. What are the examples? Cat scratch disease and LGV. LGV is lymphogranuloma venerum. LGV. So cat scratch disease and LGV, lymphogranuloma venerum. Please learn that. Coming on the next topic, we are done with granuloma also. So many topics we are covering today which are frequently asked in your exam along with your PYQs. Chalo. Thank you so much for the compliment, Pritesh. Thank you. So coming ahead. So the next question is based on apoptosis. So the question is, all of the following are true about apoptosis except. So what is not true about apoptosis? Can you tell me? The 4 options are: inflammation is present. Is it false? Is it true or false? Chromosomal breakage, clumping of chromatin, and cell shrinkage. You tell me which among the 4 options is false about apoptosis. First you give me the answer, then I will tell you the correct answer. First you give me the correct answer. Then only I will tell you. Yes, the correct answer is A, absolutely right. So let me tell you apoptosis. Apoptosis is a type of cell death. When the cell is dying, there are 2 options. Either the cell will commit suicide or the cell is murdered. The suicide is apoptosis and murder is necrosis. Okay, so there are 2 types of cell death, apoptosis and necrosis. In both of them, ultimately the cell is dying. But I compare apoptosis with suicide and I compare necrosis with murder. There is a particular reason behind that. We are not going in the detail right now. Currently, I am teaching you the apoptosis. Now, in apoptosis, what is happening? What is happening now? It is the suicide now. You will say, ma'am, why the cell commits suicide? No, this is a cell. I do not want to do suicide. I'm happy. I do not want. Now, why the cell is doing suicide? What is the reason? See, ma'am, there are 2 reasons of apoptosis. That is cell suicide. Either this cell is no more required in human body. Its job is over, its function is over. जिस भी काम के लिए cell था, उसका काम हो गया. So whatever function this cell was assigned, that is over. So this cell is no more required in human body. It will get a signal, you commit suicide. You are no more required in this world. Okay, number 1. Number 2. Its nucleus get damaged, its DNA get damaged due to any of the agent. It get damaged, either physical, chemical or biological agent. It is damaged to such an extent that it cannot be repaired. So again, the cell will get a signal that your nucleus or DNA is damaged. Now you are an abnormal cell, you are a cancerous cell, you commit suicide. So there are 2 reasons because of which the cell is committing suicide. Now whatever is the reason, either it is not required or its nucleus is damaged. It will get a signal. On receiving signal, what it will do? In the cytoplasm, certain enzymes are present. The name of the enzyme is known as caspase. Normally the caspase is inactive. On receiving the signal, either the signal is you are no more required or the signal is the nucleus is damaged. The signal is outside or inside. On receiving the signal, it will activate the caspase. What does the caspase will do? Caspase are suicide enzymes. What does they do? They convert the entire cell into multiple small cells. Entire big cell into multiple small cells. These are known as apoptotic bodies. In the end, a phagocyte will come and engulf all the apoptotic bodies. The cell is disappeared from this world. The cell is disappeared from the body. Now, when the big cell is converted into multiple small apoptotic bodies, during this process, there is no leakage outside, no leakage of cytoplasm outside. So there is no inflammation. Neutrophils or inflammatory cells will not come here because they don't come to know that something is happening. There is no leakage. That's why it's in silence. If some person is committing suicide, how does the person commit suicide? Person will not take a loudspeaker and announce everywhere, I'm committing suicide, No, it's not like that. It's silent. That's why I compare the apoptosis with suicide, because here there is no inflammation and no leakage and no inflammation. It's silent. It is doing alone. It will suddenly disappear. That's it. That's it. And here till end the cell membrane is intact. On the contrary, if someone is murdered, the person will shout, help, 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 and call everyone for the help. In the same way, whenever there is necrosis, now the cell will burst. The cell membrane will get ruptured. The cytoplasm will leak out and call the inflammatory cells. That's why I always say apoptosis is suicide, because it is silence. And necrosis is murder. There is one more reason why I call suicide and murder. Suicide is done by one person. ऐसा नहीं कि complete village is doing, complete city is doing suicide today. No, it is not like that. So apoptosis happens in one cell, single cell. But multiple persons can be murdered at a time. Take a gun, shoot multiple. So multiple people can be murdered at a time. I'm explaining you that. है ना? So the necrosis can happen. Necrosis occurs of a group of cell. So since apoptosis occurs of one cell, necrosis occurs of a group of cell. Apoptosis is silent, no leakage, no inflammation. Necrosis, the cell burst. There is leakage, there is inflammation. So apoptosis is suicide, necrosis is murder. How many of you got it? How many of you got it? So this is the definition of apoptosis. Currently, I'm giving you the detail of apoptosis, not necrosis, because our question is based on apoptosis. So whenever the cell is committing suicide by this method, now 6 things happen one by one. These are known as the 6 morphological features of apoptosis. You have to learn them in a sequence. See, this is a normal cell. I will tell you all 6 in this diagram. This is a normal cell. Now this cell want to commit suicide. Why the cell want to commit suicide? Because either it is no more required in human body, its job function is done, or else its nucleus is damaged to such an extent that it is no more required now. Okay. Now in the 2 scenario, the cell will activate the caspase. The first thing happen, cell will shrink. So earliest feature of apoptosis is cell shrinkage. It's a PYQ. It's a previous year asked question in your exam. Earliest feature of apoptosis, you can see in the diagram, the cell is shrinking. Now in the cytoplasm, we have many cell organelles. We have ribosomes, we have endoplasmic reticulum, we have mitochondria, we have multiple structural proteins. Okay, they all will come closer. Because the cell is shrinking, no? They will come closer. Since they will come closer, you can see they all are coming closer, closer, closer. So cytoplasm look more pink in color because of the closeness, compactness. Okay, this is known as eosinophilia. So the second thing happen is eosinophilia. Actually, eosinophilia is due to shrinkage only. So first thing is cell shrinkage, which leads to pinkishness of the cytoplasm, that is eosinophilia. Now the third thing is the nuclear feature. You see the nucleus become more compact. See the nucleus here and it become more compact. Compactness of the nucleus is known as pycnosis. Nucleus becomes shrink and compact, deep blue in color. And after that, it will rupture. It will fragment into multiple pieces. Nucleus fragment into multiple pieces. Fragmentation of the nucleus into multiple pieces is known as karyoraxis. So pycnosis and karyoraxis are considered in the same. So third feature is pycnosis and karyoraxis. Pycnosis is condensation of nucleus and karyoraxis is fragmentation of the nucleus. After that, on the cell surface, multiple blabs are formed. The extensions, the blabs, the cytoplasmic extensions, the blabs are formed. After that, now inside each blab, a little bit of nucleus will go. Nucleus is already fragmented now. A little bit of cytoplasm will go and the blabs will separate from the main cell, taking a small portion. So multiple apoptotic bodies are formed. They are derived from the blabs only. Each blab is taking a little bit portion of the nucleus and the cytoplasm. So apoptotic bodies are formed. And in the end, can you see a green color cell? This one, it is coming and engulfing, that is phagocyte. It is coming and engulfing all the apoptotic bodies. The cell disappeared from the world. Say the 6 features. And let me ask you the question. Say the 6 features. What are the 6 features, people? Tell me the 6 morphological features in apoptosis. See, ma'am, the first 1, 2, 3, 4, 5, 6. You get 3 questions over here. Okay? What are the 6 features? See, ma'am, first thing is cell shrinkage. The cell gets shrinked. Shrinkage, the earliest feature. After that, because of shrinkage, pinkishness of the cytoplasm, eosinophilia. Okay. After that, 2 nuclear features. First, pycnosis, followed by karyoraxis. After that, the blabs are formed on the surface. I've shown you the blabs. Then the blab will take small portion. With them, multiple apoptotic bodies are formed. And in the end, a phagocyte will come and engulf all of them. You get 3 questions. Let me highlight. Earliest feature, of course, this one everyone knows. Last feature, of course, this everyone knows. So earliest is shrinkage. Last is phagocytosis, everyone know. Let me ask the third question. Let me ask the third question. Most specific feature. What's the most specific or characteristic or pathognomatic feature? Among the 6. Specific characteristic or pathognomatic feature is the nuclear feature. Pycnosis, karyoraxis. So please read your question very carefully. If they are asked the earliest, mark this one. If they ask the last feature, the end stage of apoptosis is this one. But if they ask the most specific feature or characteristic feature, or pathognomatic feature, mark this one. Okay. And there is cell shrinkage. Cell do not swell. So this is the thing. So I taught you the 2 ways the cell die. The cell do suicide or the cell is murdered. That is apoptosis, necrosis. Suicide is done by one person. It is single cell, but multiple persons can be murdered at a time. So necrosis occurs in a group of cell. So here we have one cell, here we have a group of cell. Okay, here the cell will shrink in size and here the cell will swell in size. Here cell is shrinking. So cell membrane is intact till end. Here cell is swelling, so it will burst. The cell membrane will burst and everything will leak out. Here no leakage, no inflammation. Here leakage present, inflammation present. So here it is done silently like the suicide, and here leakage is there, inflammation is there, shouting like the murder. Say everyone, huh? Got it? So Sandhya, thank you so much for your compliment. It really gives me more and more motivation and energy looking at all your compliments. Thank you so much. So read the question now. What they are asking, read. All of the following are true for apoptosis except. They are asking which of the following is not true for apoptosis. So inflammation is never present in apoptosis. Never, never. Inflammation is a feature of necrosis. Inflammation is something that differentiates apoptosis from necrosis. Chromosomal breakage means they are talking about karyoraxis. Yes, karyoraxis occur, the nucleus fragments. Clumping of chromatin means they are talking about pycnosis. Clumping, condensation. So yes, pycnosis also occur. And cell shrinkage, yes, it is the earliest feature, it also occur. So these three things occur, but inflammation never occur. I can change the question. Instead of that, I can ask you which of the following is a feature of necrosis. Hana? So of course, again, the answer is A only, because necrosis is present in inflammation, not maybe other things are also present, but that is the thing which differentiate apoptosis from necrosis. So let's come on the next question. Next topic, I mean. Read the question and tell me the answer. The question is based on the next topic. My next topic, which I'm going to teach you right now, is thrombosis. Okay. All of the following are true for arterial thrombosis except. So among the four, which is false for arterial thrombus. Arterial thrombus grow retrograde, yes or no? It is having lines of Zahan, yes or no? It is white in color, yes or no? And it is occluding the lumen completely, yes or no? What is false? What is false? Earlier, necrosis is always pathological. Apoptosis can be physiological, can be pathological, but necrosis always pathological. It occurs only in diseases, never physiological in human body. Got it? Okay. Yes. So let me tell you the two type of the thrombus. Okay. So I will come. Yes, the correct answer here is the D, not B. The correct answer is D. No. You people are getting confused. I will come on the question again. Don't worry. First, let me explain you thrombosis. Okay. Before coming on the topic, you tell me by thrombus hota kya hai? Many of the students, I'm damn sure they don't even know what is thrombus. Thrombosis. So start from the beginning, start from the zero. I'm assuming you know nothing. I'm assuming that. Okay, imagine I'm having a cut here. So what will happen? I'm having cut anywhere on the body. I'm having injury anywhere of the body. You say, ma'am, you will bleed from that point because the blood vessel get disrupted there. So anywhere have injury, anywhere on the body, we have bleeding. The next question, how long we bleed? Say, ma'am, for the next few seconds or few minutes. After that, the bleeding stops spontaneously. Why the bleeding stops spontaneously? Thankfully, God is there and God is great. God has given a physiological inbuilt mechanism in us, which is known as hemostasis. This one is known as hemostasis. What do you mean by hemostasis? Split the term. Hemo means bleeding. Stasis means stoppage. So it is the stoppage of the bleeding automatically when we have injury. So this is a blood vessel. Let me draw a blood vessel. This is a blood vessel. See the endothelial lining. See the endothelial lining. Here the endothelial lining is disrupted. You can see this area. Here the endothelial lining is disrupted. So this is the site of the injury. I got a cut here. So this is the cut. So I'm bleeding from here, bleeding. So blood is coming out. I want to seal this area. Hemostasis, this area is sealed. So basically platelet will come and seal this area. Now blood will not come out. And after that the fibrin will stabilize it. So basically the clot is formed. This is known as clot, which is made up of platelet and fibrin. The platelet and it is thread-like fibrin. So this is known as clot. Primary clot and secondary clot. Primary clot is the platelet and secondary clot is the thread over that is fibrin. So clot is formed. It's very good. Thankfully, God has given the clot wala mechanism. So we all have 5 liters of blood. Imagine I have a cut here and we don't have hemostasis. So all the 5 liters of blood will leak out of the small trivial injury and person can die. So, but it doesn't happen. So we bleed for the next few minutes and it stops automatically because it is sealed. So it is a useful phenomenon. It's not a disease. This one is physiological and it's useful for us. Now, but imagine the other contrary. Now, imagine again there is a blood vessel. This is a blood vessel. This is the endothelial lining and there is no injury. Without injury, if the same clot is formed, again the platelets are coming and again the fibrin is coming, the primary and secondary clot. But the only thing, it is without injury. So it is a disease and this is known as thrombosis. The composition is same as that of clot, hemostasis. But the only thing, hemostasis occurs without injury, hemostasis occur with injury, thrombosis occur without injury. So it is not physiological, it's pathological. It's a disease and it's harmful for human because it is obstructing the blood flow to some organ. Say yes. Got my point? So that is the thrombus. So thrombus is basically a clot without injury. The word to be highlighted is without. It's without injury. How many of you got it? Give me a thumbs up. Huh? Got it? So that is a thrombus. You'll see, ma'am, where does the thrombus form? Thrombus are of two types. You can see this is the organ. Hai na? This is the artery supplying blood to the organ. See the arrow? The blood is going towards the organ. And this is the vein carrying the blood away from the organ. Look at the arrow. The vein is carrying the blood away from the organ. So we have an artery and we have a vein. Okay. Now the thrombus can be formed in the artery and the thrombus can be formed in the vein. Both of them are not injured. None of them is injured. But still the clot is forming in them. So it's the thrombus. It's not hemostasis. Now see the differences between them. Rather than showing you this table and asking you to learn it to mug up arterial, venous, arterial. No. Learn in the diagram. It's super simple. If you learn them in the diagram, you will never forget in your life. Okay. See, the arterial one is yellow in color. It is known as pale because it is having more platelets inside that. But the venous one is red in color because it is having more RBCs inside that. So the arterial one is pale in color or white in color because it is having more platelet inside. But the venous one is red in color because it is having more RBCs inside. That is the first difference you have to learn. The second difference, you see arterial one is partially obstructed. See, there is still a space from which the blood can move here and there. So it's always partial. It's never completely obstructive. The partial is known as mural. So I will say arterial thrombus is mural. Mural means it's partial. It is partially obstructing the lumen. And see the vein one, it's through and through. It's compact, it's complete, blood cannot pass. So this one is complete. It is known as occlusive. Occlusive means complete obstruction. So partial obstruction is known as mural and complete obstruction is known as occlusive. Okay, now the third difference is lines of Zahan. What is lines of Zahan? The alternate red, yellow, light, dark lines. And these lines of Zahan are present in arterial one. These are not present in venous one. In the venous one, I have not drawn the alternate light, dark band. You may be thinking, ma'am, what are these alternate light, dark? The dark band is RBC and the light band, the yellow one, is the platelet. So RBC, platelet, RBC, they are alternately arranged in layers. That's why the lines of Zahan are seen here. So here we have lines of Zahan and here we don't have lines of Zahan. The next difference, you will use your common sense and tell me. Tell me if the artery is obstructed. You can see here, the artery is obstructed here. So what is the effect on the organ? If the artery is obstructed, say, ma'am, artery give pure blood to the organ, oxygenated blood to the organ. Now the organ is not getting proper oxygenated blood or less oxygenated blood. So there will be ischemia in the organ. The organ will have ischemia and infarction, necrosis, gangrene. This all will happen. Okay, got it. Very correct. And now what will happen if the vein is obstructing? Venous thrombus. What is the effect on this organ? What is the effect? Now the proper arterial blood is coming. The organ is getting the oxygenated blood, but deoxygenated blood vein is not carrying away. So the deoxygenated blood will accumulate inside the organ, which will cause edema in the organ. So here the effect is edema. Got it? Say yes, this is the fourth difference between them. How many of you got it? This is the fourth difference between them. And the last one I want to ask you here. The last difference I want to ask you here. Listen, I want to tell you here, this is the point of origin of the arterial. This is the point of origin of the venous one. Arterial one, from the point of origin, it grows in opposite direction. Arterial one grows in opposite direction. This is known as retrograde. And the venous one, grows in the same direction as that of blood flow. This is known as antegrade. So arterial one grows in the opposite direction as that of blood flow. This is retrograde propagation, but venous one have the same propagation. How many of you got it? So these are the differences. Rather than reading here, you can write down and you can learn. Rather than passively reading, let's do active recall. Okay. So tell me arterial, tell me venous. Thrombus, differences. Let me ask the leading questions to you. Tell me the color of each of them. Okay, number one. Number two, I want to ask you obstruction. In which one there is partial, in which one it is complete. Then I want to ask you lines of Zahan. In which the lines of Zahan are present, in which it is absent. Then I want to ask you the effect on organ of each of them. And lastly, I want to ask you the propagation. In which direction? Antegrade or retrograde? Let's say quickly. So color, this one is white because it is having more platelets, more fibrin. This one is red. Here the obstruction is partial. That's why known as mural. Here the obstruction is complete. That's why known as occlusive. Okay. Lines of Zahan, if you say here it is present, alternate light dark, here it is absent. Effect, if you see, so here effect, here it will lead to ischemia of the organ. But this one leads to edema in the organ. And finally, if you say the propagation, this will propagate retrograde. Okay. And this is propagating antegrade. You get questions on that. Now read your question. The questions will become super simple. Read the question and tell me the correct answer. What they are asking, read the question and tell me the correct answer. Can you do so? Read the question and tell me the correct answer quickly. All are true about arterial thrombosis except what is not true? You tell me. Which of the following is not true for arterial thrombus? So is it retrograde? Yes. The lines of Zahan are present? Yes. Is it white in color? Yes. But is it obstructing the lumen completely? No. It is partially obstructing. That is, it is mural. So that's why D is incorrect. So we can create multiple questions based on this concept. The concept remains the same, but questions will be multiple. So coming on the next topic is in front of you. Read the question, tell me the answer. So coming on the next topic, just a second. Read the question and tell me the answer. Quick, fast. Yes, read the question. Which of the following is an example of type 3 hypersensitivity? So the next question is on hypersensitivity. So the four options are asthma, contact dermatitis, SLE, and autoimmune hemolytic anemia, AIHA. These are the four options you are having. What is the correct answer? Which of the following is not a type of type 3 hypersensitivity? So basically, in your FMG exam, you frequently get questions on hypersensitivity examples. There are four types of hypersensitivity, type 1, 2, 3, 4. I suggest you to learn the examples of all four hypersensitivity. I will give you four mnemonics to learn the four examples. I will give you four mnemonics to learn the... Just a second. Just a second. Let me open the chat. The chat is gone. I can see that. Yeah. So the correct answer here, you all are right, SLE. So let me explain you hypersensitivity completely. So my next topic to teach you is hypersensitivity. Let's start the next topic, hypersensitivity. So let me ask you a question. What is immunity? What do you mean by immunity? To understand hypersensitivity, first you have to tell me what is immunity. Say, ma'am, immunity is the defense mechanism. So can I call immunity is army? Defense is army. You say, yes, ma'am, defense is army. In the army, we have soldiers. So who are the soldiers here? Say, ma'am, B and T lymphocytes are our soldiers. They constitute the army. They are like defense. So whenever any terrorist enter in our body, they kill the terrorist. They do the phagocytosis of the terrorist. So my next question to you, are soldiers good people or bad people? You will say, of course, ma'am, they are very good people. We salute them. They protect us. Hana? They are forming the defense of our body. So here the soldiers are good. But imagine a soldier. Hana? The soldier, imagine a soldier, a rare soldier who become hyper excited. Hana? So we have given a gun to the soldier. He become very hyper excited. He is killing the terrorist. No way. He is killing the terrorist. But along with killing the terrorist, he is killing the country people also. Is he a good soldier? No, no, no. He is a very bad soldier. Kill that soldier. Hana? Killed. He is a very bad soldier because he got hyper excited. So when the immunity get exaggerated, it is known as hypersensitivity. So by hypersensitivity, I always remember like this. I call hypersensitivity as a mad soldier, a hyper-excited soldier who is killing the terrorist. Along with the terrorist, he is killing the country people also. So that is the hypersensitivity. So basically, the definition of hypersensitivity is exaggerated immunity. It's exaggerated, I don't know the spelling, exaggerated immunity. Okay, it's exaggerated immunity. So it is killing the terrorist, but it is harming the host body also. So there are four types of hypersensitivity. How many of you got it? How many of you got it? There are four types of hypersensitivity. So all four have different mechanism. I'm not teaching you the mechanisms in detail right now because the time is limited, but I would like to give you the examples. If you're targeting for FMG exam, one question is definitely going to come from the examples of hypersensitivity. I mean, very frequently they ask you this question. Okay. So the examples of type 1 hypersensitivity. The examples of type 1 hypersensitivity are in front of you. Type 1 hypersensitivity is known as allergy. Type 1 hypersensitivity is known as allergy. Okay, so basically all allergies will come here. How many allergies you know? Eczema is an allergy, hay fever, asthma, atopy, urticaria, anaphylactic shock, acute dermatitis. We know all these allergies, so don't learn any mnemonic for that. But if I say eczema, you say, ma'am, it's allergy. Hay fever, it's allergy. Asthma, everyone knows it's allergy. So don't make any mnemonic. But where you will confuse in the named reaction, the scientist named reaction. PK, Putzner-Kutzner reaction is an allergy, and it's type 1. Cassoni test is type 1. Thiebaud-Smith phenomenon is type 1 and Schultz-Dale phenomenon is type 1. So make a mnemonic for that. The mnemonic is PCTS, proximal convoluted tubules. So type 1 के examples क्या हैं? Say ma'am, all allergies. I know all allergies. Along with the all allergies, PCTS. So what is the full form of PCTS? The PCTS is Putzner-Kutzner reaction, PK reaction, Cassoni test, Thiebaud-Smith phenomenon and Schultz-Dale phenomenon. That is type 1 hypersensitivity. The examples of type 1. Got it? The examples of type 2, I'm having a mnemonic for you. The mnemonic is my blood group is Rh positive. So that is a mnemonic you have. My blood group is Rh positive. M stand for myasthenia gravis. B stand for blood transfusion reaction. In the blood transfusion reaction, I include Rh incompatibility also, that is erythroblastosis fetalis. Because last to last year you have a question on erythroblastosis fetalis is a type of which hypersensitivity, and you got confused. So it is type 2 only because it is one of the blood transfusion reaction between the mother and the fetus. Na Rh incompatibility. G stand for two things: good pasture and Graves. Good pasture syndrome and Graves disease, the 2G, both are important. I is ITP, not very important. R is rheumatic fever. H is hyperacute graft rejection, and P is pemphigus vulgaris. So you have to learn the full form. Okay. There is a special type of type 2, the hyperstimulated form of type 2, which is known as type 5. So type 5 is a type of type 2 only. So among all these examples, 2 are actually type 5. So let me tell you which 2. 2 of them are actually type 5. I call it Mahatma Gandhi, myasthenia gravis and Graves disease. Mahatma Gandhi, MG. So actually these are type 5. MG, myasthenia gravis and Graves disease. So if you get a question in your exam, myasthenia gravis or Graves disease, any of them, the question is on one of them, is an example of which hypersensitivity? And your 4 options are A, B, C, D. Your 4 options are type 1, type 2, type 3 and type 4. So because type 5 is not given in the option, you should go with type 2. But if imagine one of the option is type 5, so it's better to go with type 5 because actually they are example of type 5, which is a version of type 2 only. But if type 5 is not given in the option, go with type 2. I hope you got it very clearly. So Mahatma Gandhi, learn it separately from this. My blood group is Rh positive and Mahatma Gandhi. From this take out 2 and these are actually type 5, which is a hyper stimulatory form of type 2. So please learn that. Okay, got it? So can I go ahead? The third is type 3 hypersensitivity. What are the examples of type 3? The mnemonic is SHARP, S-H-A-R-P. The mnemonic is SHARP. S is actually triple S and P is actually double P. So actually S and P are only important, but you have to learn all. S, triple S is serum sickness, Sheik test and SLE. SLE frequently. Currently question is on SLE only, our current question. But you get question on Sheik test also, serum sickness also. H is purpura. A is arthritis reaction. R is reactive arthritis. And P is PAN and post-streptococcal glomerulonephritis. Polyarthritis nodosa and post-streptococcal glomerulonephritis. So that is the 2P you can see. So you have to learn. And 4, type 4 is John gave tulip popcorn to Hashi. Okay, John is John motor reaction. What is tulip? Tuberculin and lepramin. Tulip. What is pop and corn? Pop is pernicious and corn is contact dermatitis. Popcorn. Hashi is Hashimoto thyroiditis. So it's very easy if you learn that. It's very easy. Let me tell you. So what is type 1, type 2? We will quickly revise type 3 and type 4. Can you tell me the examples? Type 1 example, say ma'am, all allergies. Number 1 plus PCTS. That is type 1. Type 2 examples, my blood group is Rh positive. Okay. What are the examples of type 3? SHARP. SHARP. It's triple S and double P. And type 4 examples, John gave tulip popcorn to Hashi. So please try. If you have written the mnemonics, half job is done. Now the next half you have to learn the full form. I'm not saying the full form, but you frequently get questions on that. Now have a look on your question. I always come back on the question. Okay, so that you get it clearly. I can change it in multiple forms. See, I'm asking type 3. I'm asking in the question type 3. So what is the mnemonic of type 3? I told you SHARP, SHARP. Apply the mnemonic, S is coming here. So SLE is my answer. What if I change the question to type 1? In the type 1, we have all allergies with plus PCTS. So asthma is the allergy, my answer will become this. If I do type 1. What if I do the type 4? If I do it type 4. In the type 4, we have John gave tulip popcorn. Corn ka jo C hai, that is contact dermatitis. In that case, my answer will become contact dermatitis. What if I do it type 2? Type 2, my blood group is Rh positive. Blood transfusion reaction. So one of the blood transfusion reaction, you can say it's autoimmune hemolytic anemia. So it will be type 2. How many of you got it? So I can change the question multiple times. The answer will change multiple times. So you get many questions, the examples of this. So can I come on the next topic? Let's leave the Hodgkin's lymphoma. Okay. So the next topic, I shall take this one. Okay. Read the question and tell me the answer. Very important. MI. The next question is based on MI. That's myocardial infarction. Can you read the question? Tell me the answer. Read the question. What is the question? Histopathological findings 12 hours after ischemic injury to the heart is. So I'm asking ischemic injury to the heart. After ischemic injury to the heart, I mean MI. After 12 hours of MI, What will be present in the heart? Is it carrier excess of myocytes? Is it new capillary invasion of the myocyte? Is it hypereosinophilia of the myocyte or coagulative necrosis of the myocyte? Yes, very correct. The correct answer, it is incorrectly marked. The correct answer is D. It's coagulative necrosis. By mistake, this one is marked. Now, the correct answer here is D. Coagulatory necrosis of the myocytes occurs at 12 hours. So what if I change instead of 12 hours to 6 hours to 4 hours to 3 hours or 24 hours or 1 week, I can change it 12 times. Questions. So let me tell you all about MI. Can I start? MI, myocardial infarction. In myocardial infarction, there is ischemic injury to the heart. Can you see the heart diagram? There is a heart in front of you. Now in this heart, can you see the left ventricle? This is the left ventricle. Let me highlight. This is the left ventricle. So I'm interested in left ventricle. When the left ventricle is doing the systole, it is contracting, the blood is coming in the aorta, and via aorta, the blood is distributed in all the organs, the pure oxygenated blood. But for contraction, you see the wall of the left ventricle. In the wall of the left ventricle, these are the cells I'm drawing. These are known as cardiomyocytes. These will contract. Then only the systole will occur. So who is giving energy to these cells to do the systole? Who is doing ATP, oxygen? So they also require blood. So heart is contracting, the left ventricle is contracting, but for contraction, for systole, it requires energy. So who is giving? So it receives blood via coronary. Can you see the coronary arteries? Let me show you the coronary arteries here. So from the aorta, the artery is arising. That is known as coronary artery. Let me show you the coronary artery. Can you see from the aorta, this is the coronary artery. The coronary artery is arising from the aorta and supplying the blood to the wall of the left ventricle like this. So the wall of the left ventricle is getting the blood, getting the energy, getting the oxygen. It contracts and it gives blood to the aorta. Now imagine if one of the coronary is obstructed. Let me obstruct the coronary. If this coronary is obstructed, so these small coronaries will not have blood in them. Any one focus. For example, these coronaries don't have blood because the big coronary is obstructed. So it is not. So this portion of the heart is not getting blood. So the cells present in this portion, they will undergo necrosis. They will die. And this is known as myocardial infarction. It is irreversible. How many of you got it? So patient have severe chest pain and the heart stop functioning. The left ventricle is not contracting. Aorta is not getting blood or less blood. All the organs is receiving less blood or no blood. Person can die because brain do not get blood for 8 minutes. Person will die. Kidney do not get the blood for long. Acute renal failure, person can die. So because of this, the person can die. How many of you got it? This is MI. In MI, the coronary get obstructed. The reason can be different. Maybe due to atherosclerosis, due to vasospasm, due to thrombosis, due to embolism. Whatever is the reason. The point is that the coronary got obstructed. If the coronary got obstructed, that portion of the left ventricle is not getting blood. And any organ that is not getting blood, the cells of that organ die because of coagulative necrosis. So here necrosis will occur. So here necrosis will occur. Got my point? Now, imagine this person is dead. This person, they having MI, it is dead. This person is dead. There was another person at the time of death with this person. So we asked the other person that what happened at the time of death. So the other person is saying the person was having severe chest pain. I think it's MI. And after that, before we shifted to the hospital, we call the doctor, we call the ambulance. The person is dead. But the police is suspecting a foul play over here. The police is suspecting a foul play. Maybe it's a medical legal case. Maybe the cause of death is something else. And this person is saying it's MI. But how we believe that it's actually MI? So we will order a postmortem. There is a postmortem or autopsy on this dead body. Now imagine this dead body is in my hospital and I am the doctor who is performing the postmortem on this body. So what I will do? I will take the heart out. I will cut and I will take the heart out. Now in the heart, being a doctor who is performing the autopsy on this heart, this is the heart. This is the right side of the heart. This is the left side of the heart. So in the wall of the left ventricle, I have to look for MI. If I get the MI over here, I will make my postmortem report, autopsy report that I got a MI over this. And if I don't get, I will mention that. If I get MI, it is not necessary that I have to just get it, whether I got or I didn't found the MI. The timing of the MI is important. For example, the MI is present. I got a scar. The MI is present. I mentioned, but maybe this MI is 10 years back and now the cause of death is something else. If you ask the wife of this person, she is saying yes, 10 years back she was having my husband was having the heart attack. So maybe this is the scar of that. And now the cause of death is some poisoning or something else. So the timing of the MI is important. So for knowing the timing of the MI, there are 10 best timings, 10 different timings are possible. So we have to make a slide. Okay. So what I'm doing, I'm the doctor who's performing the autopsy on this dead body. This is the dead body in my hospital. So first thing I will take the heart out. This is the heart out I have taken in a tray. This is the right side and this is the left side. Now I'm interested in the ventricles. I will cut the ventricles into slices, multiple slices. Each slice 0.1 centimeter thickened. I will cut into slice by slice. I will cut it completely. Multiple cut. I will do it. So in the multiple slices, I'm cutting it, and each slice will like this. In each slice, there are two lumens. This is right ventricle. This is left ventricle. So I have to look for MI in the walls of the left ventricle. In the walls of the left ventricle, I have to look for MI over here. Where is the MI? So I'm having hundreds of slices with me. Many slices I will cut. So in each and every, I have to take it and look for the MI with a magnifying glass. You see, ma'am, it's a very tedious job. What if the MI is very small over here, maybe in the anterior wall, it's very small, and you miss it? It may happen. It's a very small scar. You are looking at grossly. You can miss it. So what is the solution of that? The solution, there is a dye. There is a dye. The name of that dye is TTC. Triphenyl tetrazolium dye. So what I will do, I will take a jar, a big jar. A big jar, a big vessel. I will fill the dye. TTC in that. I will put all the slices of the ventricle here. All the slices. I'm drawing only one, but I will put all. So this is the right ventricle lumen. This is the left ventricle lumen. Now I'm looking whether the left ventricular wall have scar or not. So TTC will give red color to the viable area. All the slices will become red in color, except the dead area, except the scar. The scar will be yellow in color. So you will see the slice like this. In the slice, you can see this is the scar. In the slice, you can see this is the scar. So scar look yellow with TTC, and rest of the slice will be red in color. So with this, we will come to know whether scar is present or absent. Now, if the scar is present, we have to make a slide for knowing the timing. So there are 10 time zones are possible. These are the 10 time zones I'm showing you. So I will show you 10 diagrams now. Based on that, you will decide what is the timing of the MI. MI to hai. In the dead body, this is the person who is dead. I took the heart out. I cut the heart. I put all the slices into TTC. And this is the scar I found. I found a yellow color scar. So I'm damn sure MI to hai. Boss MI to hai. But MI is half hour old, 4 hour old, 12 hour old, 24 hour old, 3 day old, 7 day old, 10 day old, 14 day old, 2 weeks old, 8 weeks old, or 2 months old. I do not know that. So in my report, I should mention the MI is present and what is the timing of MI. For that, there are 10 possibilities. I will show you 10 diagrams. So I will cut this area and make a slide, HNE slide, and examine under microscope. Based on the appearance of the slide, I will decide the timings. How many of you got it? So it is only important in medico-legal cases whenever we are doing the autopsy. Say yes, people. Respond. Are you people live? You are not responding. From a long time, you are not responding. Got it? Can I tell you the 10 timings? So first learn the 10 time zones. Then I will show you the 10 diagrams correspondingly. Okay. So first 4 are in hours. How I learn? Let me tell you. The first 4 are in hours. 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. 24 hour is 1 day. So the next 4 are in days. So 1 to 3 day, 3 to 7 days, 7 to 10 day, 10 to 14 day. And 14 days are 2 weeks. So the next 2 are in weeks. So 2 to 8 weeks, 8 weeks is 2 months. So this is how I learn. So first thing you have to learn the, just a second, what happened? Just a second. How this, whatever I'm saying it is, how this captions will go. Just a second. Let me see. I guess there is some setting. It's done. Okay. What I was telling you, the timings. Okay. So the first 4 are hours. R, and R. This is how I learn. The next 4 are days. The one of them is week and the last one is in month. Now fill the numbers. It's easy. 4 are hours, 4 are days, then week, then the week, then the month. Now fill. See, ma'am, 0 to half hour. Okay. Half to 4 hour. Okay. 4 to 12 hour and 12 to 24 hour. We are done with hour. 24 hour means 1 day. Now come on the day. So say ma'am 1 to 3 day, 3 to 7 day, 7 to 10 day, and 10 to 14. 14 day matlab 2 week means 2 week. So it is 2 to 8 week. And 8 week means 2 months. So more than 2 months, everything looks same. So this is the first thing you have to learn, the 10 time zones. Now correspondingly, I will show you 10 diagram. I'm the doctor who's performing autopsy on this dead body. This is dead body. I took heart out. I cut the heart into hundreds of slices, 0.1, 0.1, 0.1, 0.1 centimeter. I put all the slices in TTC and I got the scar. So I'm damn sure MI to hai. there is scar, but I'm not sure. MI abhi ka hai ki purane? If I mention in my report the MI is 4 hours ago and the death is also 4 hours ago, so police will correlate, yes, death is also 4 hours ago and the doctor is saying the MI is also 4, so MI is the cause of the death. In my report, if I mention the MI is more than 2 months, I don't know whether it's 10 year, 20 year or maybe 1 year, but it is more than 2 months. But that is now. Death is not 2 months ago. So they will say, ki, yes, MI to hai, but it is 2 months ago. But now the cause of death is something else. So it is the job of the police who will investigate. It is not my responsibility. I am a doctor. I will make my postmortem report. In this in this dead body, I got MI and the age of MI is this. That's it. That is my responsibility. I will make a good postmortem report and now the police will correlate accordingly. How many of you got it? Huh? So let me show you the 10 diagrams, people. Shall I show you the 10 diagrams? Huh? The first one, in 0 to half hour, it's always normal. You don't find anything. So up to half hour, we can miss the MI. है ना? Morphologically. Half to 4 hour, we get only waviness. We get only and only waviness. What do you mean by waviness? Let me show you. So can you see? See the lower half of this diagram. Just a second. See the lower half of this diagram. Can you see the lower half of this diagram? In this diagram, you can see the waviness. I mean, these are the cardiomyocytes, these cells. Normally, they are straight. In these cardiomyocytes, you can see the nucleus is there. This is the nucleus. This is the nucleus. This is the nucleus. You can see the striations is there. These all are striations. Normally, they are straight. Everything is good, but only thing they are wavy, they are wavy, they are wavy. So earliest change is waviness, which is seen at half to 4 hour. It's your question. Half to 4 hour, you get waviness. After that, 4 to 12 hours, you get coagulative necrosis. Only coagulative necrosis, nothing else. See the upper half of this diagram now. Can you see the upper half of this diagram? You can see, again, you can see the cardiomyocytes. But see, inside the nucleus is gone. The nucleus is disappeared and there is dark pink color bands are there. Striations are also gone. So only outlines are maintained, the inner details are lost. So this is coagulative necrosis. So there is coagulative necrosis that 4 to 12 hour, there is coagulative necrosis. 12 to 24 hour, along with coagulative necrosis, a few neutrophils are there. Can you see the upper half again? The same diagram. You can see these all cells are neutrophils. If you see them, they all are multilobated. A few neutrophils are there. Hana? After that, still coagulative necrosis is there, but along, it is not few. There is abundant brisk neutrophils. Now see this next diagram. You can see the coagulative necrosis is still there, but see in the background have abundant of neutrophils. Now next, at 3 days, 3 to 7 days, the neutrophils start falling and macrophages start appearing. Now in the same diagram, you can see I'm highlighting some cells. The diagram is very small. You cannot highlight. These cells are macrophages because they don't have multilobated nucleus. They have only one nucleus, mononuclear. These are macrophages. So neutrophils start falling and macrophages start appearing. What are macrophages? Macrophages are phagocytes. They eat the dead tissue. So they start eating the dead muscle. So once the macrophage will come, see the next diagram. The lower half have the dead muscle, but the upper half dead muscle is not there. The necrotic coagulative necrosis is not there. It is already eaten by these macrophages. So it is known as granulation tissue. So the dead muscle will disappear and granulation tissue will come. Initially only at the margin and then complete granulation tissue followed by collagen and scar. So this is the 10 time zones. Let me fill it. It's very easy, very easy. So say the 4 hour and say the 4 days. Day. Tell me 1 week and 1 month. You are aware what I'm talking about now. So tell me the 4 hours. Say, ma'am, 0 to half hour. I know you have to learn the split. Half to 4 hour. 4 to 12 hour. 12 to 24 hour. I know this is the 4 hours I'm talking. Okay, tell me the days now. Days. In the days, we will say 24 hour is 1 day. So 1 to 3 day, 3 to 7, 7 to 10, and 10 to 14. 14 days. So we will end here 14 days. 14 days means 2 weeks. So we will say 2 weeks, 2 to 8 weeks. 8 weeks means more than 2 months. Oh my God, it's again. Okay. So more than 2 months. How it will go. Okay, I will do it. Chalo. If I do the escape now, whatever I have written, it will go and I have to write it again. Listen, let me escape it once and come back. What's happening? I don't know. Chalo. So we will do it once again. Okay. So quickly let me do it. I'm not saying, I'm just writing. I hope you got it. Hana? Okay. So we are having the 4 days and we are having week. We are having month. Let me fill it quickly and I will tell you in a sequence. If you don't change the sequence now, the things are super simple. If you don't change the sequence, you will learn in a sequence. Hana? I will tell you the sequence. It's very easy. Okay. And 10 to 14. Here 2 to 8 weeks and more than 2 months. So we are done. Listen. So first we have normal. We miss it. Number one. Number two, we have waviness. The earliest finding is waviness. The second finding. After that, we have only coagulative necrosis. After that, along with coagulative necrosis, we have few neutrophil. After that, along with coagulative necrosis, we have brisk or abundant neutrophils. After that, neutrophils will fall and macrophage will increase. As soon as the macrophage word come, I think it's a phagocyte, it start eating the dead muscle. So the granulation tissue start falling. Initially early granulation tissue and later on the complete granulation tissue. And finally, the collagen will be there and finally the scar will be there. Say yes if you got it. Say yes. So this is a diagram of the scar. Everything will disappear in its scar. So I've shown you the 10 diagrams over here. Now you frequently get questions in your exam like what? They will give you one of the finding. They will give you the finding like this. The brisk neutrophils with coagulative necrosis at what timing? Few neutrophils at what timing? Macrophage first time appear at what timing? And you will get the confusing options among them. So you will get confused in your exam. And now currently the question is on 12 hours. 12 hours. Where is 12 hours? Can you see in this diagram? Where is 12 hour? 12 hour is this, है ना? 4 to 12 hour. At 4 to 12 hour, we have coagulative necrosis. We have coagulative necrosis. So my answer is coagulative necrosis. I told you. How many of you got it? But it is not necessary every time they will ask you at 12 hour. They can ask you 24 hour. They can ask you 32 hour. They can ask you any hour, anything, any timing. So based on that, you can correlate. Give me a thumbs up if you all got it. Everyone give me a thumbs up if you all got it. Do you have any confusion till now? You liked the lecture? You understood it well? So I taught you many topics. Along with, in each topic, there are many PYQs hidden. It is not, for the sample I have put one PYQ, but inside each topic there are many PYQs which are repeatedly asked from in the FMG PYQs from that particular topic. So in this way, topic by topic, we have completed many important things here, many PYQs here. So currently the time is over. I guess I should stop here. Okay. So let me tell you one more lecture I am having. Let me announce that and then after that we can end. So thank you so much for being with me. Thank you so much for your patience and for your cooperation and for your precious time and for your trust in me. Thank you so much. But believe me, whatever I taught you, it's worth watching. If you are an FMG aspirant and you have understood all these topics, you can expect many questions in your exam from these topics. So it was worth. It was not a waste of time. It was worth utilizing the time here. Thank you so much. Wishing you best of the luck. You have we have very few days left in your exam and I know you are going to rock. All the FMG aspirants who are watching me live now, you are going to rock. Believe me, I have belief in you and you have to keep my belief. Okay, once you get cleared your exam, once the results are there, don't forget to ping us, Hannah. Drop a message to the team or drop a message to us that just let us know that I got cleared. So to always feel happiness, you know, whenever we see such messages that we have contributed somewhere in your success. Wishing you all the best for your exam and I know you are going to make it this time. Give your best shot. Whatever the best you can do now, give your best shot this time. The most important strategy during the last minute is the revision. Do more and more and more revision and the PYQs. Just solve the PYQs. Don't focus on any new topic right now. It is not the right time to focus on new topics. Don't give any GTs now. Don't give any mock tests now. It will demotivate you. Hannah, if you don't get the good score, it will demotivate you. The most important thing here is the now confidence. Whatever knowledge you have gained in the last 6 months, now your confidence should reflect it. Thank you so much. Wishing you all the best, all of you. With this, I just want to end my session. Okay, thank you so much. I'm having one more session planned on this YouTube session channel only. That is Pharma Part 2. So that is a detailed rapid revision. It's not PYQ. Remarkable rapid revision Pharma Part 2. That is on 13th of January. So if you are interested, you all can join me live. It is 6 p.m. onwards. Thank you so much. Bye-bye. Wishing you all the best. I'm ending the session.